overlap between us, but I am sure some of the things he will elaborate, some things I will elaborate. Marchifawa-Bignami disease, then we have toxins, alcohol, drugs, then hexachlorophene and chronic solvent vapor abuse. Then we have hypoxic ischemic. This is one thing which we need to remember, because we are seeing more and more about hypoxic disorders now. And young people coming with hypoxia following cardiac arrest has becoming a very common event now. Many of them are film actors, cricketers, you know their lifestyle, you know what they are up to. Fitness is most important, and with that fitness almost top on the list and diet on the next, they will have massive cardiac arrest followed by that hypoxia and gets admitted to the ward in ICU with hypoxic brain damage. And we have seen few of them already now, and you must be hearing in the newspaper every other day about 40-year-old person in hypoxic brain damage, and that is due to cardiac arrest. Referred to you some of these cases. So, demyelination is a big basket, and this demyelination we need to rule out whether it is primary or secondary demyelination. Since we talked about the primary, we just recollect or recapitulate what we discussed yesterday in two cases. The first case vignette I will be talking about as 25-year-old lady, decreased vision in both eyes and urinary urgency 1 year, recurrent episodes of paresthesias and imbalance while walking 8 months, incoordination of the limbs, speech difficulty, imbalance, urinary urgency 2 months. So, we know what we are talking about here. The patient on examination, a young lady, had a pale optic disc, and it was right side vision is 6/24, left was 6/24 with nystagmus and with a gaze dependent, then bilateral brisk reflexes and extensor plantar and cerebellar signs. Patient had paresthesia and imbalance. Most often it is due to the posterior column which is causing the problem, and that I emphasized yesterday, that you must remember that sensory symptomatology is much more important when we are talking about primary demyelinating disease like MS or NMO-SD. Then the differential diagnosis, naturally we will think in terms of either multiple sclerosis or in the form of NMO-SD. So, you can see the next picture is MRI, and MRI in this slide in the T1 you may not presented with tingling and numbness of both the lower limb for 6 months, upper limb for 5 months, imbalance while walking for 3 months and double incontinence. And cranial nerves were normal, increased tone in the lower limb with brisk DTRs and plantars were extensor, bilateral corticospinal tract involvement, and sensory and touch pain decreased by 50% in both the lower limbs below knee. That means here we are adding one more component, that the peripheral nerve is involved associated with the spinal cord involvement, and what could it be? And here is a white matter lesions which we are seeing on the top, which is very blotchy, and it is seen in the frontal and parietal region. One is periventricular region. What is this is a question. Is it, are we talking about something different here? And what we seen is different. Serum agglutinin titer for brucella is 1 in 320, and the blood culture for brucella was positive. And brucellosis is one of the other white matter disorder which comes. So, you have to remember this, especially in certain pockets, and I am sure Saudi Arabia still is seeing large number of brucella cases, and there are publications, if you see in Saudi Arabian journal which has been published regularly, they see lot of brucella abortus giving rise to these white matter disorder, but we need to keep it in mind. We also see in some cases very rarely at Nieman's practice. Brucella can present as a chronic meningitis, demyelination, myelitis, myeloradiculopathy, and infective CVT also, and abnormal MRI findings which include the basal meningeal enhancement, almost mimicking like tuberculosis. So, when you are having like tuberculosis with white matter disease, white matter lesions like this, do not make a diagnosis of tuberculosis. You do not get it in tuberculosis, this white matter disease. So, when you have something with a meningeal enhancement and you have a CSF which is abnormal and you have white matter lesion which affect both the brain and the spinal cord with the peripheral nerve involvement. I am stressing peripheral nerve involvement here because we do not make a diagnosis of TBM there. So, you need to think in terms of whether it is brucella, and those are the clues, and with that we can make a diagnosis of brucella. Then comes another case which is a 21-year-old lady. Initial presentation was raised intracranial presentation, features with focal neurological deficit. So, the CT and MRI, this is very interesting case, and we had a lot of discussion on this with a space occupying lesion, right medial temporal lesion, basal ganglia is involved. Possibility of ADEM was considered. Started on steroids, initially patient improved, subsequently there is a rapid worsening with cranial nerve involvement, and then patient has subjected for decompressive craniotomy on suspicion of a neoplastic lesion. You can see that there is a complete immunoline was negative, HIV VDRL negative, pathology test was negative. And what we see here, there are definite right temporal basal ganglia, thalamus, midbrain, necrotizing lesions with focal hemorrhages, thrombosed small vessels, mainly the veins. I am sure you must have guessed what I am talking about. Perivascular inflammation, predominantly histiocytic and lymphocytes and polymorphs. Patient progressed downhill course, succumbed following sepsis, multi-organ failure. Fortunate at NIMANS, in such cases we always get autopsy, and Anita Mahadevan comes running, and Shankar did the autopsy here at that time. We always remember Shankar whenever we are talking about autopsy, and here we consider these differential diagnoses. This differential diagnosis, whether it is neoplastic, whether it is infective, tuberculosis, fungal, protozoal, toxoplasma, amoeba, because meningoencephalitis with a lesion, and if it is a lesion with hemorrhages, even we consider a possibility of amoeba. We had amoeba infection of the brain also, Naegleria, which has affected that. That is the reason. Then vascular, thrombotic, inflammatory and immune mediated. Here you can see the surgical resection which has been done, then vascular thrombosis and necrosis. And I am again suggesting here veins were involved here. So, we are talking about venulitis and vasculitis, phlebitis here. We see phlebitis. So, in summary, what did we see? Necrotizing lesions with hemorrhage, thrombosis and necrosis of the small parenchymal venules, variable perivascular inflammation, polymorphs, lymphocytes and histiocytes. And then Anita worked up further, T cells surrounding veins, and B cells are very fewer, veins are involved, there are focal cups of polymorphs around the blood vessels, and then we have vascular occlusion by fibrin and perivascular inflammation. And these are worked out, and special stains were done because we had to rule out other infections like toxoplasma, and Giemsa stain for fungi was ruled out. Immunostains for HSV, CMV, toxoplasma, all were negative, and there were no neoplastic cells. I think yesterday's surgeon was here, he was talking about the glioma and neoplastic cells. Here there were no neoplastic cells. So, what is it? Vasculitis in deep and superficial dermal vessels, and now we know that is nothing but Behcet's disease, and it is a Behcet's disease which we have, and there are some criteria, and one of the criteria which I have hidden before presenting that was recurrent oral ulceration, and these are the criteria for making a diagnosis, and this patient had definitely the recurrent oral ulcerations plus eye lesions and cutaneous lesions. Dryness of the eye, it is not uncommon. This condition we are seeing, one need to keep that in mind, and Behcet's bears the name of a Turkish dermatologist, Behcet, who described the triad of recurrent oral and genital ulcers, uveitis in 1937, and multiple disease of unknown etiology characterized by venulitis in almost any tissue, and it is noted to be in a high risk in the Silk route. It is described as a Silk route covering parts of the Middle East countries as well as India and also the other parts of Pakistan. And Behcet's disease in India appears rare, but it is there. I am sure we are missing many of these cases. Why I say so? Last week I was in Bhubaneswar, and they presented a tough case saying that what is this case, and when we look at it, classical, it was a Behcet's, and patient is still in ICU for more than 1 month, and the patient is almost on the downhill stage, and nothing could be done. They have done all the things possible, all IVIG, everything was given, nothing has helped, and the patient was downhill. So, more often mucocutaneous and arthritic rather than ocular, and neuro onset is later, pathology test is often negative. You must make a diagnosis, and HLA-B51 has to be looked for. HLA-B51 is positive. In this patient whom I saw, we did ask for HLA-B51, and they communicated to me next week saying that it is positive. straight away we can make a diagnosis that it is nothing but Neuro-Behcet. The word Neuro-Behcet has been now coined in 1954, and neurological involvement when it occurs very serious, morbidity and mortality is very high. And these are the involvement. I do not want to go further because of lack of time, and it is reversible partially with steroids. And then what is tumefactive? It looks like tumor, and the first case was discussed in 1987, and then at that time 15 cases were reported. Now we are seeing more and more also. We have to keep that in mind, and most often these cases diagnosis has to be done by biopsy, otherwise we will not be able to make a diagnosis. Why I showed this case is again a fulminant course white matter disease. Keep that in mind whether you are talking about Neuro-Behcet. Then move on to further quickly 2 more cases. I want to show about 10 cases, and where variety of the demyelination is there. 45-year-old lady, behavioral changes since 1 year, incontinence and cognitive decline since 6 months, dependent on all ADL since 1 month, retropositive illness. So, once you know it is retropositive, diagnosed 2 months ago, then MMSE can do only naming. Dysarthria were present, TTRs were brisk bilaterally. So, we always consider a possibility of HIV associated dementia or encephalopathy. And what do we see in the MRI? MRI shows bilateral white matter disease which are affecting bilaterally symmetrically, and it is a large lesions which are seen, and atrophy. We are talking about a middle aged or younger person, and you can see the atrophy. The moment you see the atrophy of that degree in an MRI in a young or a middle aged person, always think about HIV or retropositive case, and retropositive causes cerebral atrophy like that. Here we need to see the MRI. MRI characteristically shows bilateral, patchy, relatively symmetric white matter, hyper intensities and confluent, and more often ill defined hyper intensity in the subcortical and deep gray white matter also, and no contrast enhancement. That is very, very important, and no diffusion restriction is seen. This we need to differentiate from that of a PML. Always whenever we have a white matter disease in HIV, differentiate that from PML. How do I differentiate? In PML it is always patchy. You do not see bilateral symmetrical as we saw in this case, and it can be unilateral or bilateral. More often it is in parieto-occipital. We have seen so many PML cases with HIV setup, and under HIV setup we have seen, and it was earlier diagnosed as only postmortem, but now we can make antemortem diagnosis, and if you treat these patients vigorously with antiretroviral drugs with protease inhibitors, patients can survive. Earlier it was only postmortem diagnosis, now we are making, and patients are surviving. I have patients of HIV positive with PML surviving even at the end of 6 years. That is what you have to remember. And HIV encephalitis is usually confluent, symmetric, posterior fossa involvement, and subcortical U fiber. That is what is very, very important, are spared here in encephalitis and involved in PML. This is very, very important differentiation between PML and HIV encephalitis. Quickly moving on to the 9th case, that is 63-year-old, 1 year ago, following which notice he was slow, progressive difficulty in walking, falls and shaking of trunk occurs. Abnormal eyelid movement, very interesting case. He is a 63-year-old, and what is important is a 1 year only, and abnormal eyelid movement, hallucinations, swallowing, speech difficulty since 1 month, went to Hajj pilgrimage. That is a clue there. Hajj pilgrimage for 1.5 years ago. From then onward he had fasted. Fasting was there for a long time there, and patient had come here on examination, had lingual dysarthria. When you have a lingual dysarthria with a movement of the tongue, orofacial dyskinesia, saccades are broken, bilateral cerebellar signs are there. What is it? Lingual dysarthria, when we talk about it, Whipple's disease. Whipple's, always we consider a possibility in a case like this, and what is the Whipple's will show causative bacteria is the Tryphophthicum whipple. Systemic infection, 33% of patients have this experience. Neurological symptoms including encephalopathy, ophthalmoplegia, myoclonus, ataxia, upper motor neuron signs, and hypothalamic manifestation, and symmetric midline high T2 signal intensity involving the hypothalamus, midbrain and mesial temporal lobes, and they are the characteristic features of Whipple's disease, which one need to remember, especially in a long fasting patients, and they come with they present. Lingual dysarthria gives a clue, because very few conditions are associated with that. Then here is the last case, I think. 47-year-old lady had seizures 3 months ago, was admitted elsewhere and was treated, and after that decreased appetite, nausea and vomiting, had a persistent hyponatremia. That is the clue there. Fatigability since 10 days, is unresponsive since 7 days. Patient is mute, not responding to commands, spontaneous eye opening, catatonic, rigidity of all the limbs. What is that? Osmotic hypomyelination syndrome one need to consider, because of a short history, and this light is too much for this. We can see a white matter involvement in the pons. Here you can see that pontine involvement there, very characteristic, and you can see the subcortical involvement there, very characteristically seen. What is this? Nothing but osmotic hypodilution, hypodemyelination syndrome. These are central pons and extrapontine sites could be there, usually seen in alcoholism and chronic nutritional deficiency with electrolytic abnormality. To this list we should add our own now. We had seen in COVID cases, post-COVID. After the COVID has over, there were patients, 3 patients came to us with central pontine myelinolysis. We had a classical pontine myelinolysis, which are not due to the hyponatremia or not due to the correction, because these patients were seen after 1 month after the COVID was over, and this patient was admitted and COVID and very slowly corrected, everything was done, but these patients developed central pontine myelinolysis, and best part of it was all the 3 patients survived, and best part, prognosis is very good, and the patient is being followed up. Even last week I saw 2 of them came, and both patients are doing normal. The central pontine myelinolysis, again a postmortem diagnosis earlier. Now patients can survive. So osmotic demyelination syndrome, I think the time is not there. This is just to mention about Sjogren syndrome. Here is a 74-year-old lady presented with white matter disorder. Presented with white matter disorder affecting, almost looks like multiple sclerosis. So you can see that elderly, is it MS? We always think that, is it MS in a 74-year-old lady? Very unusual. We can't think about that. And this patient is from Nagpur, Bhopal. Patient had come from Bhopal, and this patient had white matter disorder, and you can see here almost like dozen fingers, but there is corpus callosum is totally spared, and this patient Sjogren was positive, and this was a Sjogren syndrome. We need to think about it. The nerve biopsy, small vessel vasculitis, salivary gland necrotizing vasculitis. We should think about it. Lip biopsy can be done, or corneal biopsy can be done, which could help in making a diagnosis of Sjogren, because dryness of the eyes are very component, a very important component here. So the diseases that mimic or resemble MS include CADASIL, vitamin B12 deficiency, CNS syphilis, EDEM, CNS vasculitis, Devick's disease, Sjogren syndrome, sarcoidosis, CNS lymphoma, Lyme disease. I am not talked about many of these conditions, because I am sure, I think Mishra will take up, and some of them he will cover it up and then complete the whole picture. So what is the take home message? Not all white matter lesions are MS. That is my message. So, or NMO. Don't think that just because it is a white matter, you are considering a possibility of multiple sclerosis or NMO. Differential diagnosis for secondary demyelination needs to be considered. Proper clinical history is extremely important, especially for our younger colleagues who are students. You have to take the history, not just looking at the MRI. Your history and examination and analysis of the symptom always plays a very important role. Thorough general physical examination, neurological examination is very important, and relevant laboratory examination would support the diagnosis. Thank you for patient hearing.
Thank you, sir. Any questions now? Shall we take questions now or later on?
Maybe after the.
chairpersons, ladies. Breakdown, inflammation, and astrocytic gliosis in multiple sclerosis. And in acute stage, the differentiation between demyelinating lesion and normal is not very clear. And therefore, this is no clear border is seen, whereas in chronic lesions, you can see a border. In the chronic plaque, you will see a demyelinating lesion, and then it is when they do not confirm these findings, and some of the papers are also that the reverse is also reported. So this is all confusion. Schilder's disease has been already mentioned, is a diffuse sclerosis, single or multiple large supratentorial lesions, found mainly in children and has severe clinical course. Bellows concentric sclerosis has been mentioned by Satish, and we saw a 10-year-old boy, fever for 2 days, 23 days back, and then diminution of vision, weakness of upper and lower limbs, spastic speech, and dysphagia. And he had normal development before he developed this illness. And you can see we initially considered ADM and stroke, but then the lesions turned out to be that of Bellows concentric, because you can see the concentric pathology in the lower part of the MRI. Marburg variant of multiple sclerosis is a severe clinical picture. Both supratentorial and infratentorial lesions are seen, and poor prognosis. NMO will be discussed in the next talk, so I don't go in detail about it. Behcet syndrome was mainly mentioned. Quite a number of these patients are missed because the oral and genital ulcers are not given due importance, and therefore we commit a mistake. And then when somebody points it out, we go back and then the diagnosis is confirmed. Sjogren syndrome, again, dry eyes and dry mouth. You know, quite often elderly patients have dryness of mouth, and in diabetics it is quite common and is not given due importance. But then again, if we start seeing this, every patient will appear to be Sjogren. So therefore, a criteria of about 6 months of dryness of mouth is very important and should be given due importance. And of course, you can have myelitis, optic neuritis, and MRI lesions are demyelinating, which has been so well explained earlier talks. And of course, the patient will have other features like Raynaud's phenomena, lung, kidney, liver, GI involvement, and endocrine abnormalities, and then antibodies are helpful. SLE. All of us have seen cases of SLE. We were confused with multiple sclerosis. Patient present with ocular optic neuritis, one side or two bilateral. But here again, I recall a patient where optic nerve involvement was there. Then it was not a demyelinating. It was a total vision was lost, and therefore usually in demyelinating lesion you will have some vision in majority of cases, and then they will be reversing. P100 will be prolonged. Whereas if you have a total optic atrophy, you think of vascular lesion, vasculitis, or some other collagen disease, and therefore that's the pointer. Here we have arthritis, malar rash, the serositis, renal involvement, and then antibodies, anti-dsDNA, EPLA, etc. are positive. Myelitis in multiple sclerosis is very interesting and is known as leukoid myelitis. I recall a patient who, this is a 40 years old lady, presented with visual impairment and developing paraplegia. So multiple sclerosis was the diagnosis. And later on you again search and find out multi-system involvement. I think diagnosis of multiple sclerosis rests not only on the clinical criteria, but also ruling out other causes. Secondary causes is a long list, and as is evident that anything which involves the subcortical white matter, whatever etiology, will lead to a demyelination, and then all the demyelination is not multiple sclerosis. And here these are 5 cases of myelitis in SLE, and you can see that these patients are all females. In 2 of these cases, the myelitis was the presenting feature, not SLE features, and then they can be cervical or thoracic depending on what level is involved, and then they can be variably treated. Sarcoid, well, it's again a diagnosis of exclusion. You have to rule out almost everything looks like sarcoid. You have to find out etiology and look for the lungs, lymph node involvement, CNS and peripheral nerve involvement, and CNS involvement about 5 to 15%. Leptomeningeal involvement occurs, and of course the diagnosis will rest on demonstration of non-Casgerian granuloma. Leukodystrophies, again, whole lot of demyelination. I'm not going to go into that. And Lyme's disease, of course, was mentioned by Satish, and it can present in the acute stage as meningeal meningitis-like picture. Later on, heart, meninges, and meningoencephalitis may occur. And in chronic stage, you can have hematological and cardiac abnormalities. High index of suspicion is required, and if you think of it, if we try to investigate, sometimes you are rewarded. ADM is again a common diagnosis all of us have seen. This case I would like to emphasize: a 23-year-old girl presented with fever, diarrhea, vomiting, drowsy, incontinent, power 3/5, and she had pedal edema. GCS 14, spasticity, tendon reflexes bridge, joint position impaired, clinical impression ADEM. But when you look at the fundus, you find a hemorrhage, macular hemorrhage. And then the investigations are interesting. 33,000 platelet count, MCV 103, bilirubin 1.8, transaminase raised, reticulocyte count 3.4, tibial SCP not recordable, vitamin B12 83, MRI inverted V sign. So this was a case who presents fulminant acute ADM-like picture, turns out to be B12 deficiency. This is the girl who was given B12 injection. I mean, it's the first time we had seen acute picture. What we have learned is subacute, subacute combined degeneration. The whole thing is subacute or chronic, found in old people. But here is a young girl who is presenting with ADM-like picture. And then day 1, after treatment, she became consciousness improved. Day 1, she became alert. Day 5, she was able to sit unsupported. Day 10 was continent. Day 10 walked with support. Day 15 walked and discharged. So this was a new learning for us, and this was published in Postgraduate Medical Journal. I can show you a video. Patient is walking, but believe me, I can't get this video at the moment. Anyway, then we treat the patients with rheumatoid arthritis or collagen disorders with immunosuppression. And this is a 72-year-old female, rheumatoid arthritis for 18 years. Etanercept with methotrexate for 18 months. Headache, she presented with headache, instability, walking difficulty for 1 week. FNAC of the demyelinating lesion revealed that she had a demyelinating pathology. Etanercept was stopped and patients started improving. The lower panel will show the improvement in the demyelinating lesion. So when we treat the patient with immunosuppression, many times, especially with biologics, you can say demyelinating lesions, and what is to be done is just hold on and the patient improves. Now, I'm repeating this picture. Now I'm going to B12. This is the inverted V sign, spinal cord involvement, subcortical white matter, and the last column you see severe atrophy. In B12 deficiency, sometimes you can see severe brain atrophy. And mind you, in HIV myelopathy and B12 deficiency, identical. There is no difference. And therefore, we have to see that if you see a sensory, we burnt our fingers. We had a patient, sensory ataxia, spasticity. We thought of B12, we gave him B12 treatment, not improvement, worried, HIV positive. So we have to keep that syndrome in mind, and sometime it can be. Now, B12 deficiency is not a demyelinating disease. It is, in demyelination, you have immunological mechanisms, perivenal demyelination occurs because of immunological alterations. Whereas here it's a myelinolytic disease. The myelin goes off in the patchy focal areas. Central nervous system is mainly affected, and myelin loss occurs, and there is no remyelination. The whole thing disappears, and later on subsequently remyelination is not seen in that way. And there are no inflammatory change, there are no cellular infiltration. Mainly astrogliosis occurs, and neurons are not affected. So the differentiation is in multiple sclerosis you can have axonal involvement. Now there are papers that axons can be affected, but here axons are primarily not affected. Now the pathology here is cortex, spinal cord, nerve and vision, optic nerve. And the clinical syndromes which we saw out of 82 patients, mainly it was myeloneuropathy. You can have myelopathy, myeloencephalopathy, all combinations are possible, and encephalopathy only is very rare. Peripheral neuropathy isolated occurs very rarely. Mainly it is a spinal cord involvement. Myelopathy is the most important. With that you have encephalopathy or neuropathy or myeloneuropathy, encephalopathy combinations. Now you see, we have been taught that beetle deficiency is a deficiency disorder, and all we have written and passed our exams by saying it is a deficiency disorder. But quite a number of these cases have a immunological abnormality. They may be associated, antiparietal cell antibodies may be positive. So this helps us to differentiate the immune mediated and the non-immune mediated patients. So this is what we did. We compared 28 patients with antiparietal cell antibody positive, antiparietal cell negative over 28 cases. So this was the idea given by editor of a journal. So we did that comparison, and to our surprise we found no difference. Antiparietal cell antipositive were 50% and 50% were negative patients. Their clinical presentation, their outcome, their pathological abnormalities, they're all identical. So there is no difference. So because the common pathway is similar, whether it's immune or non-immune, the things are similar. So it's a common pathway, and therefore there is no difference in their clinical picture or the outcome. I mean, these are the evoked potential studies which we did. Central motor conduction abnormal. Normally it is 18 in our lab, and here you see 25 and 22 in right and left side. So severe prolongation or suggesting of severe demyelination. Then this was the somatosensory evoked potentials most frequently abnormal. Most common abnormality will be SEP, and we also know that sensory ataxia, spinal cord affected, posterior column affected. So that's okay. So mainly in SEPs 55 cases. Not recordable were 13 in antibody positive and 17 antibody negative. Prolongation 11 and 7, normal 3 and 4. So no difference in the evoked potential abnormality, and so is visual evoked potential. Now visual evoked potentials, visual functions in B12 are quite often we are told that it leads to optic involvement and optic neuropathy. In autopsy there are reports of optic atrophy and optic nerve involvement, but it's extremely rare. Evoked potential studies before our study were reported by Fine. In 5 out of 10 patients, evoked potentials were abnormal. Now, this is an interesting study which one of our students, our colleagues at that time, students at that time, now he's a big professor, he has done. And we had 17 patients of, subacute combined degeneration, and visual functions were tested in detail, and none of them had any abnormality. Color vision, field of vision, everything was checked, and visual functions totally normal. But look at the evoked potentials. So mild prolongation in 2, moderate prolongation in 10, and marked prolongation in 5 patients. And here I show you a VEP of 122 improving after 6 months to 100. So severe prolongation, totally asymptomatic patient has nothing, no visual symptoms, but if you test you find it like this. The importance is that quite often we have patients who present with spondylotic myelopathy. They have sensory, may have ataxia, they have spasticity. If you get their VEP abnormal, think of B12. So that became an interesting thing that we started seeing all the patients with spastic quadriparesis or spondylotic myelopathy. We check their VEPs, and if they're abnormal, we check their B12 levels. In multiple sclerosis, quite often you see cognitive and behavioral abnormalities, and Charcot also said memory loss and dull mentation was noted by even Charcot at that time. Patients with multiple sclerosis quite often have behavioral abnormalities and they are depressed. Now, In subacute combined degeneration also we have mental abnormalities. There may be acute confusional state, paranoid behavior, affective disorder, and organic deterioration was reported by in as early as 1937. Pernicious psychosis and megaloblastic madness also has been reported in literature. Hilton et al. In 1991 had done 151 cases of betel deficiency, cognitive impairment in 7, and psychiatric abnormalities, depression, agitation, and hypomania in these number of patients which I have mentioned. We studied 36 patients, aggression, rigidity of thoughts, delusion, anxiety, and visual hallucination, 5 cases. Paranoid behavior in 1, grandiosity in 2, idea of reference in 1. Mind you, referral diagnosis by neurologists or physicians was schizophrenia in 2 and Lewy body dementia in 1. So these patients can mimic anything, any dementia, Alzheimer, Lewy body dementia, and delirium, and so on. We did the cognitive evoked potential studies in these patients of subacute combined degeneration, and you can see that you can't see the P3 in that column earlier, but after 3 months of treatment, you can see the P3 levels are marked here. P3 waveforms are marked here, showing they become recordable and at a long latency. This shows the summary of our work here, that compared to in these 36 patients, mini-mental score was abnormal in 47, and P3 was abnormal in 45% patients. And you can see the red one is the normal, and the blue column is the P3 level in the patients. So it is so much prolonged. Severe prolongation of P3, suggesting of demyelination again in the subcortical white matter in the and which improves, shown in this slide. At the baseline, P3 levels have been plotted in blue, and after treatment of 3 months, you can see so much of significant improvement occurs in P3 levels. So suggesting that there are cognitive changes which are very well responsive, and they respond very well. I'll show you. Now, when we did this study, the editor pointed out that you have done mini-mental, you have not done the detailed psychometry, and therefore this paper, though being published, but it is very incomplete. So we did again. We did detailed neurobehavioral studies and all mini-mental scale and trial making test and motor speed precision test, Benton visual attention, and many test batteries were done. And we found again same thing, cognitive abnormalities 42% and P3 abnormalities in 58%. And the patient had features of subacute combined degeneration, cognitive abnormalities, and spinal cord dysfunctions were seen. The behavioral abnormalities, anxiety, irritation, apathy, aggression, hallucination, delusion, etc. were recorded in these patients. The clock drawing test, the initial one is shown first, and at 3 months you can see the improvement and the corresponding MRI finding. Mini-mental score also shows improvement with treatment at 3 and 6 months. This is just an interesting case. This abusive incontinent businessman, 29-year-old man, graduate, with 10-year history of disinhibited behavior, paranoid behavior. He used to file FIR of his neighbors and was a great nuisance in the community. He had urinary fecal incontinence 3 to 4 times per month, and he was on olanzapine and was being inadequately treated by psychiatrists. Tendon reflexive wrist, ankle absent, joint position could not be tested properly, and again he had low B12. B12 level was 1400 because he had received the injection just before. And you can see the knuckle hyperpigmentation, oral stomatitis, and then his his clock drawing test very poor. You can see inverted V sign and knuckle hyperpigmentation. He was a case. So after this study, we concluded that his behavioral abnormalities are suggestive of mainly frontal temporal involvement. And then we did the SPECT studies, and we found the same in these patient. So the cognitive and behavioral changes are also common in vitamin B deficiency neurological syndrome. They're associated with P3 abnormalities, and they're associated with subacute combined degeneration in majority. So if a patient is cognitive impaired, if you can test the joint position sense, and reflexes will be hyperreflexes. So the patient will have spinal cord involvement. In addition, he would have cognitive involvement. But sometimes they are delirious and they are not cooperative, so then you have to depend on lab tests if possible. But the interesting thing is this striking improvement in the cognitive changes. When you treat them, after 2-3 days, 5 days, on day 1, the patient starts showing improvement. So what is the mechanism of this improvement? It cannot be remyelination. You see, when there is a myelin pathology, you expect all the improvement will occur because of remyelination. But remyelination will have a temporal sequence, it will take time. It will not happen that quickly. So that was the question in our mind. So what is the mechanism? Or is it remyelination or is something else? And then vitamin D deficiency, vitamin B12 deficiency, in adults we know now there is spinal cord involvement, maybe encephalopathy, and maybe peripheral involvement, or maybe the combination. But what about in children? Children do not have these features. In fact, subacute combined degeneration in children I have not seen so far. So they present with entirely different syndrome. In elderly, this presents because of the echlorhydria, atrophic gastritis, H. pylori infection, and they receive anti-diabetic metformin, and this interferes with the absorption of B12. But in children, they are, they're unlikely to be nutritional deficiency. Child is, unless the mother is deficient and he's transmitted deficiency from the mother. So why it happens in the children is the question. And in literature, it is said that is the elderly, middle-aged, elderly people develop B12 deficiency. But what is the mechanism in children? Not much known. And the pathology in the children is mainly poor brain development, poor growth or growth retardation, feeding difficulty, sometimes lethargy, tremor, irritability, and brain atrophy. I mean, these are the syndromes. Now, vitamin B12 is absorbed from the stomach by intrinsic factor, and it requires a protein that is megalin and tubulin to transfer it into the cell, and then from the cell it goes from the stomach it goes to the body and then into the other cells, and where again it is transferred to transcobalamin. Now this absorption and deposition process requires a number of proteins, and which can be, and then there are other mechanisms in the body. One is methionine synthesis, which is affected by cobalamin deficiency, and other is in the mitochondria. This helps in certain other reactions which lead to lipid formation, etc. So these mechanisms can be affected by genetic abnormalities, and the absorptive defects can require inherited deficiency of intrinsic factor, transcobalamin 1 and transcobalamin deficiency, and there can be mutations in tubulin and megalin. And therefore, the patient will present with high methylmalonic acid, homocystinuria, and variable neurological dysfunctions, which I have told you in children. Again, I will come back to it. And the metabolism abnormalities can be because of tubulin-related enzymes, which are a large number of enzymes. I will not go into those details, and they result in white matter abnormalities and delayed myelination. Now I'll tell you another interesting, I'll finish very quickly. Not very quickly, but I'll take a little more time. Now this is the 3 months old full-term normal delivery, Apgar score 1 at 5 minutes. Brother 4-year was normal, and he was anemic, and he had to be given 1 transfusion in early days. He was lethargic, irritable, unable to hold neck, unable to roll, no bisyllables, and could not wave bye-bye, and vision and hearing were normal, which were expected to be at that stage. 5 kilogram, gray hair, patchy alopecia, neck drop, DTR normal, no liver spleen, no lymph node enlargement, no myoclonus, no movement disorder. Hemoglobin 6, platelet count 64,000, TLC 2,400, B12 below 150, homocysteine more than 50. Brain atrophy. Treatment, B12 was, he was given a B12 injection weekly for 6 weeks and then monthly. And the child showed remarkable recovery. He started holding neck, he started sitting, he started standing, and became normal. Then we checked the B12 of the parents also, and both were having below 150. So this is a genetic disorder Now, we have not been able to specify which genes are affected, but then mother and father both are B12 deficient, child is presenting with severe deficiency, you treat and it is remarkably improving. Homocysteine was also raised, 21 and 19 in these patients. Now look at this MRI. On admission at the age of 19 months, MRI shows so much of atrophy, 18 months MRI is recovered. So atrophy is going back to normal. I mean, this is very, very rare. I have not seen in many conditions, but then it is very, very fascinating. Now, we all know that nutrition B12 deficiencies are there, and we have increased requirement at different stages of life and during pregnancy and lactation and so on. Yes, it's an important nutrient and it should be kept in mind and it should be given. And the food items containing B12 are shown in this here. The vegetarians have very poor possibility of acquiring B12 because you have to drink about 2 liters of milk per day to get one microgram of vitamin B12. So it's a very difficult thing to have adequate B12 through for vegetarians, and then vegans again are a great difficulty. So the nutritional component is there, but then if there's a genetic predisposition, it becomes aggravated. So in children, the clinical picture of vitamin B12 deficiency is very different. It is mental retardation, pallor, hypotonia, convulsions, hypoglycemia, and stroke. Mind you, the patient which I showed you, the businessman, also had seizures. So in advanced cases, encephalopathy, B12 deficiency can lead to seizures and should be kept in mind. Now I come to nitrous oxide. Now, it's both a recreational drug and occupational hazard. Sometimes we have learned that anesthetists who work with nitrous oxide for a long time may develop subacute combined degeneration-like syndromes. It is reported in literature. But in UK, crime survey 2013-14, 8% of 16 to 24-year-old people were taking nitrous oxide. And it's very interesting. It has a well-being. It has no lasting effect, and it's very popular. It's easily available. You can carry it and sniff it when you want. And of course, if the B12 deficiency, the clinical picture gets aggravated, and the clinical findings are very similar to what I have shown you. There is spinal cord involvement, and there may be optic nerve involvement. But the more interesting thing is nitrous oxide leads to inhibition of cobalamin, and which interferes with the action of methionine synthase, which results in further reaction, and therefore, because of this inhibition, homocysteine level rises. So we try to learn about demyelination, we try to study nitrous oxide as a model, and we expose some rats. My PhD student, exposed some rats with nitrous oxide, 1.5 liter per minute for 90 minutes for 1 month. And then we could show homocysteine levels rising. Of course, that the model was okay. And this model was published as a model for demyelination. And then histopathological changes were also depletion of myelin and vacuolation were reported. And you can see in the exposed group there are myelin dysfunction and myelin changes are seen. Ultrastructure also shows vacuolation. The vacuolar pathology which I showed you was also demonstrated. And it could be prevented if you pre-treated the patient with B12 injection. And we also looked at subacute combined degeneration patients in the symptomatic and asymptomatic group, and we looked at the oxidative stress markers in the blood, and we found that there was severe oxidative stress in these patients of asymptomatic and symptomatic B12 deficiency. The pathology here is that because of the TNF-alpha, is if the B12 deficiency, their TNF-alpha levels are raised and the endothelial growth factor is reduced, and therefore there is an abnormality. And if you give supplement, these changes are reversed and the recovery occurs. So there's a different pathology here compared to multiple sclerosis. So primary and secondary demyelinating diseases are well known and we have been discussed in detail. The secondary disorders, ADM, collagen vascular disease, toxic nutrition, or any pathology which affects the subcortical white matter or spinal cord will affect myelin. B12 deficiency is common and can mimic many disorders, and it's the most cost-effective treatment to eliminate a large number of disorders. So we should not give it blindly. We should make the diagnosis and then treat it. Treatment is very simple. It's not hazardous, and it gives remarkable results if correctly, appropriately used. And nitrous oxide is a good experiment model for demyelinating disorders. Thank you very much.
Thank you, sir. I think we keep the questions in the last now. We'll move on to the third topic. Dr. Sujita. Dr. Sujita is head of the department. Sorry, I think she is working in Apollo Hospital, Ahmedabad. I don't know, but she was a senior consultant there, and then she held previously she held a post of head of the department in RM Neuro Hospital and DJMC Civil Hospital, Ahmedabad. This is over to you, ma'am.
Good morning, everyone. I think it's like, Sachin and Sehwag have already come for the batting in the opening, and they have already won the match for India. So after that, to come and talk after two stalwarts, it's a little difficult. Luckily, I'll be concentrating on a small part that Dr. Satish Chandra talked about. I've been asked to talk on treatment approach only for antibody negative NMOSD. So when we think of treatment approach, the first thing is the correct diagnosis. And diagnosis, I can't stress more for the students here. This basically depends on your history taking. History taking is so important. If you have not asked for, say patient comes to you with diminution of vision, he says both I can't see anything, both eyes. And actually patient has not noted earlier that one eye was affected earlier. And now because the second eye is also gone, now he thinks that it's both eyes, sudden vision loss. And you see optic atrophy in one and the other eye is still showing just diminution of vision or acute changes. Similarly, you have to have the past history. You have to ask about that history about uveitis and dryness of eyes and other vasculitic manifestations, previous episodes. So with all that correct history and of course your examination, then you proceed on to further diagnostic. Then we go on to the NMOSD criteria and all. Yesterday, I think whole day we discussed a lot about all types of NMOSD. So basically there are two broad categories here, aquaporin positive and negative. Almost half of the patients who turned out to be negative were MOG positive, and we had one full lecture on MOG antibody disease yesterday. In addition, there is this small proportion which is negative for both. Positive, it's very easy. You have, for diagnosis, you need only one criteria and aquaporin 4 positive. But when you are suspecting something and both antibodies are negative, then what do? You go back to pathophysiology. Yesterday I showed you this diagram with beautiful picture of the vascular endothelium, the blood-brain barrier, and aquaporin 4 antibodies on the food processes of astrocytes, and the MOG antibodies on the oligodendrocytes. And in the top picture, yesterday we discussed about the blood-brain barrier being breached. There has to be a breach in blood-brain barrier for these antibodies which are formed peripherally to enter the CNS and then cause that astrocyte damage, which is complement mediated. And in the second picture down there, you see the MOG positive, where you are seeing mainly the oligodendrocytes affected with relative preservation of astrocytes. Now, when you have both these antibodies are absent, then how is the damage occurring? And we still have some clinical picture which is very similar to this. So obviously we are missing some antibodies there or yet to be discovered that we don't know about. So basically the pathology forms with aquaporin channels, aquaporin 4 antibodies binding to these receptors and causing damage. As the aquaporin 4 are located mainly in retina, optic nerves, the spinal cord, hypothalamus, cerebellum and the periaqueductal region, we are going to get features relating to these areas mainly. So the typical picture is either long segment myelitis, optic neuritis, area postrema syndrome, which is mainly with recurrent vomiting or hiccups, and the diencephalic and cerebral symptoms. But these have to be associated with specific MRI features. So in 2015, they formed these international consensus diagnostic criteria. For the aquaporin 4 positive, as I said, there was only the one core criteria and aquaporin 4 positive antibodies and ruling out other diagnoses. Similarly, for the aquaporin 4 negative NMOSD or those where they could not test aquaporin 4, unknown status, these different criteria have been advised. So here you need at least 2 core clinical characteristics, and these should occur as a result of one or more clinical attacks, and they have to meet all the following requirements. Okay, so there has to be history of one or more clinical attacks. Out of these, the essential things are at least one core clinical characteristic must be either the optic neuritis or the myelitis or the area postrema syndrome. These are the 3 main ones. So out of these, one should be present. And secondly, there should be dissemination in space. That means there should be 2 different places where it is affected. It could be either optic nerve and spinal cord, or it could be optic nerve and the brainstem, or could be the the area postrema syndrome and the optic neuritis. So you have to have dissemination in space, at least 2 or more different core clinical characteristics that it comes to. And there is essential additional MRI requirements. We'll see about that later. Negative aquaporin 4 antibody is the other second criteria, and it is important to exclude other diagnoses. Now here all our other differentials are important, whether it is vasculitis or it is like SLE, Sjogren syndrome, connective tissue disorders or sarcoidosis, or various infections including brucella, syphilis. All these can present with similar features with optic nerve and cord involvement. So exclusion of alternative diagnosis is equally important. So what are the core clinical characteristics? One is the optic nerve, so optic neuritis. Second is the myelitis. Third is area postrema, which is in the dorsal medulla. Fourth is the brainstem syndrome, which could be involving pons, midbrain. Then comes the symptomatic narcolepsy or the acute diencephalic syndrome with NMOSD typical diencephalic MRI lesions. I'll show you those just after this. And there could be symptomatic cerebral syndromes. This is not like multiple sclerosis, where you patient might present to you with optic neuritis and you are seeing multiple lesions in the brain, but those are asymptomatic. That is not a core clinical criteria for NMOSD. It has to be symptomatic cerebral syndrome. So whatever lesion you are seeing, it should also give some clinical manifestation. So what are the additional MRI? These are quite stringent criteria. The acute optic neuritis. One thing it requires is that the brain should be normal. Either it should be normal or only some non-specific like white matter ischemic lesions that we see, tiny lesions. That is allowed. Or it should show optic nerve involvement with T2 hyperintense lesions or the enhancement of optic nerve should be involving more than half of the optic nerve. So the length of optic nerve is important, or it should involve the optic chiasma. So it should be more of posterior involvement involving optic chiasma or more than half the length of the optic nerve. For myelitis, the requirement is that it should be long segment, meaning it should cover at least 3 spinal segments. So, and sometimes patients present with past history suggestive of myelitis, where you may see only the cord atrophy. So even there the cord atrophy also should be for more than 3 segments, spinal segments. That is the criteria for the myelitis part. And area postrema syndrome requires associated dorsal medulla lesions, and the brainstem lesions, periependymal, we'll just see. So the first one, you can see there are pointers there, the first one, where you can see the central cord involvement. It should not be a peripheral or dorsal cord involvement. It should be central cord involvement and involving more than 3 segments there. On, and there is no pointer here. You can see the optic nerve involvement, T2 for more than half the length of the optic nerve, and lower down here you can see the optic chiasma and the posterior part of the optic nerve being affected. Same here, the optic nerve in the coronal section. There again you can see the posterior cord going right up to the area postrema region. Here you see it better, the area postrema involvement, and on top you can see the brainstem lesion there also. Lower down here again dorsal medulla, and these are the periependymal lesions I was talking to you about, the diencephalon. We'll see later. Yeah, there. So now diencephalic and the cerebral lesions. You can see the difference between the MS and NMOSD. They are not involving the corpus callosum, but you can see the periependymal lesions there in all these. So there are some key points to be noted here. There should be at least one clinical attack. It's not like you just see changes accidentally on MRI and diagnose it as NMOSD. You cannot. There should be one clinical attack at least. The second is NMOSD cannot be diagnosed in an asymptomatic lesion, the same thing that I talked to you about. No clinical characteristic specifically indicates NMOSD. Even if you see optic neuritis, you see long segment myelitis, or you see area postrema, that does not mean that it has to be NMOSD. Even if you see area postrema, that could also be ischemic. Just as there is no clinical characteristic which specifically indicates NMOSD, there is no characteristic that rules out NMOSD either. And multiple clinical characteristics must be present in the absence of aquaporin 4 IgG seropositivity for a diagnosis. In the absence of seropositivity. So what are the red flags? This was a very good slide shown yesterday also. So there are certain clinical findings which are atypical, and you must be aware, you must make sure that you go to the correct diagnosis or take further investigations. If the course is progressive, that is very unusual for NMOSD. It's usually in relapses. If you see very acute, less than 4 hours, then that is unusual for NMOSD. It is more likely to be vasculitic. If it progresses for more than 4 weeks, that is also unusual. For, as we discussed in the first one, progressive course is very unusual for NMOSD. Third thing is a partial transverse myelitis is very odd. What you see here, what I showed you, the central cord is more likely with NMOSD, and partial transverse myelitis is very unusual. And if you find CSF oligoclonal bands, then that is also it's a red flag for NMOSD. If you have suspected sarcoidosis, or cancer, then think again, it may not be NMOSD, investigate further. Certain imaging characteristics like some brain lesions, like Dawson's finger, like projections, what you saw earlier in the earlier talks as well, perpendicular to lateral ventricular surface. Then you think again, this is probably not an NMOSD. Adjacent to lateral ventricle or the periependymal lesions are seen more in NMOSD, but those adjacent to lateral ventricle in inferior temporal lobe, it's unusual for NMOSD. Juxtacortical with subcortical U fibers, again unusual. Cortical lesions, beware, though we are seeing cortical lesions here, but make sure that you are treating NMOSD and no other things. What sir said about brucellosis, we are seeing a lot more of brucellosis now in our setup, because I had a patient, a young girl actually, with a lesion which looked like, they said this is GBM only. Definitely GBM with so much of edema and large lesion in the parietal lobe. And in fact, we went ahead and the surgeon operated, and he said the brain doesn't look like tumor at all. And he just took a biopsy and came out. And biopsy was negative for malignant cells. In the meanwhile, we had sent for brucella, it came positive. Within 6 months, the lesion has completely disappeared, and she is absolutely fine. So we are seeing more and more, not just meningitis, but also classical lesions, and there could be hemorrhagic areas with brucella. So they look very much like either metastasis or a malignant lesion, and we need to think of brucella more, because a lot of our patients are farmers and they are in touch with cattle, so they are likely to have that. So any cortical lesions, we need to be sure what we are treating and always send for other investigations. Persistent gadolinium enhancement is again unusual for NMOSD. If we see I just recently had a patient who came with history, very typical elderly man with difficulty in walking, tending to fall and becoming more and more drowsy. We said, you come down, we did the MRI, bilateral cerebellar lesions more on one side than the other, and going on right through the brainstem, right up to the white matter, along the white matter through the brainstem. And we tested for so many other things, and we said this is definitely NMOSD looks like, but there was significant enhancement in that cerebellar lesion. So our radiologist was very adamant that this is probably not NMOSD, and he did turn both aquaporin 4 and MOG were negative. Everything else came negative, sarcoid came negative, all other. We said we should test for brucella. There was no hemorrhagic component there, but even that was negative, and we treated him with methylprednisolone, thinking that this could be just MS or what, but there were no other lesions of MS there, and I'm still not sure what I'm treating there. Coming to the spinal cord lesions, if it is involving less than 3 complete vertebral segments, think again, it may not be NMOSD, and it should complete the criteria. That is another important thing. If it is in the peripheral cord, that's a red flag. And again, indistinct signal changes on T2 sequences is again a red flag for NMOSD. MOGAD we discussed a lot yesterday. In short, younger age of onset, lower female to male ratio, different racial more seen in Caucasian. In children, they present with edema or optic neuritis. In adults, optic neuritis almost in 88%, bilateral more than unilateral, and myelitis in almost 56%. There could be brainstem involvement in 24%, and both encephalitis and seizures are known. Antibodies targeting MOG have been identified in both children and adults with a variety of phenotypes as we discussed. They can present with so many different things. Associated autoimmune disorders. Yesterday we discussed a lot about what all other things patient may be associated with, and it was found in 1/3 patient of aquaporin 4 positive patients, but only 9% of MOGAD. So that is less common with MOGAD. Now coming to differential, the main differentials are of course when you have antibodies negative, NMO and MOG positive and MS. So what are the differentiating factors? One thing, age is almost the same for MOG and MS, around 30, but MOG can be seen in children also, and NMO is usually around 40 years. For sex, predominant female presentation in MS as well as in MOG, slight predominant, but not in aquaporin 4 negative NMOSD. Clinical phenotypes, we have already discussed a lot about this, and we discussed the criteria just now. Relapsing course for NMOSD, that is very important, and same for MS also, but MS could be progressive also. Type of relapses, usually optic neuritis and long segment myelitis relapse in NMO, whereas in MOG it is usually the optic neuritis that relapses. In MS could be anything, it can present as anything. The MRI lesions, we discussed about the NMO lesions. In MS, MRI is always abnormal, and presence of Dawson's fingers and subcortical S-shaped fibers, it's very typical. Whereas in MOG, you can have various different types of lesions. You can, thalamic and pontine lesions are more common compared to NMO in MOG. And you see extensive inflammatory lesions in the optic nerve because that is a major presentation. MRI, we have discussed CSF. Now, in NMO, you can have more than 50 cells in CSF. That is very important. Whereas in MS, it should be less than 50. And in MOG patients, pleocytosis may be variable. So what all investigations will you do? Definitely the routine investigations, but along with that for sarcoid, ACA levels, calcium, you will do chest CT to find out if there are lymph nodes. For ruling out collagen vascular, ANA profile, aquaporin 4 antibody, MOG antibody, and the vasculitic picture. MRI and of course evoke potential tests. So progress in treatment of NMO disorders, novel insights in therapeutic possibility. This was recently published in April 22, and this is a nice diagram that they showed. Yesterday I discussed quite a bit about the newer antibodies available now, monoclonal antibodies, and here in this picture you can see all the various antigens where all injury can occur and the therapeutic targets. As you can see there, the therapeutic targets, glucocorticoids and plasmapheresis, where you can see the, I wish I had a pointer, and the first line therapies. You can see plasmapheresis and glucocorticoids acting at both the blood-brain barrier and filtering out the antibodies, and also the MMF and azathioprine and human IVIG has been shown as first line therapy acting on the T cells. For second line therapy, they have shown methotrexate and cyclophosphamide. Discussed that yesterday. And the newer biologic, as you can see right in the beginning here, eculizumab, it basically acts on the complement. So it prevents the cleavage of complement into C5a and B, and that is where it prevents the cytotoxic damage due to the antibodies. Similarly, you can see tocilizumab and satralizumab, both acting on the IL-6 and preventing the inflammatory cytokine action, leading to less inflammation and preventing further damage. And inebilizumab, that acts on CD19 receptor of the B cell. Where is the rituximab gone? it should be on CD20, yeah. Rituximab and Hitech-City down there, yeah. Inebilizumab on CD19, rituximab on CD20, and the stem cell. Right. So basically NMOSD treatment, the first line treatment is either methylprednisolone, plasmapheresis, immunoadsorption or IVIG. We talked a lot about this. Plasma exchange as early as possible should be the main treatment for NMOSD. Along with the present guidelines do say that it should be glucocorticoids followed by plasma exchange, but better to do plasmapheresis between 8 to 23 days. That is what has been shown to be most effective. Azathioprine and MMF have been used more and more, especially in India, because these are more cost effective. But rituximab is now taking over. We are seeing a lot more improvement with just 2 sessions to be given for 1 gram on day 1 and second dose after 15 days. And the next further rituximab sessions will be every 6 months. We talked about inebilizumab, tocilizumab, satralizumab and eculizumab yesterday quite a bit, and all these monoclonal antibodies are to be used where we are seeing refractory NMOSD. Cost is a prohibitive factor there. The earlier the plasmapheresis, better the response. I showed you similar diagram yesterday. If we can do plasmapheresis within 10 to 12 days, then you get very good EDSS improvement between 60 to 100%. Some other biomarkers now for NMOSD. We discussed about GFAP yesterday, whether it is possible to do GFAP assessment in CSF for our patients. Right now it is not available. Maybe it will become available soon. The other biomarkers are T helper 17 cells, cytokine. They T helper 17 related cytokines. These levels have been shown to be increased in NMOSD. Both IL-6 and IL-17 were higher in NMOSD than MS, and Th17 cells and cytokines may be the therapeutic targets in future. GFAP increased in NMOSD, CSF levels correlated with serum levels and likely to be biomarkers of disease activity, and if so, we might be able to decide when to stop treatment for NMOSD, at least the aquaporin 4 positive or the MOG patients. About CXCL1, CL5 and CL17 in CSF. These are neutrophil related cytokines, elevated in NMOSD but not in MS, so that may help in the diagnostic criteria. These do not correlate with the clinical severity and may be helpful for diagnosis. Similarly, exosomal microRNAs. Now HSA-MIR 122 3P and HSA-MIR 200A and 5P. These correlated with the disease severity in NMOSD. Now these are all experimental models, may be potential as biomarkers later on. So new therapeutic targets. Yesterday we discussed about cetirizine, bortezomib and all these helping in the treatment of NMOSD patients, and these are interesting parameters. What are the other therapeutic targets? One is IL-27 T helper cell 17 pathway. It may be involved in the pathogenesis of NMOSD without aquaporin 4 IgG. So in these where we are searching for other antibodies, it may be helpful to have these assessed soon, and we might get an answer to those, what is the cause of aquaporin 4 negative NMOSD. So coming to special categories, as we said, aquaporin 4 channels are present in so many places in the body. They are also present on placenta, like hypothalamus and all. So what is the relation to pregnancy? One is because they are present in hypothalamus, They may lead to low FSH and LH and cause infertility. These channels are present in placenta and may cause miscarriage. There are higher rates of relapse in early pregnancy and postpartum. So now what is the treatment for that? If there is an acute relapse during pregnancy, then you can give IV methylprednisolone or can do Plex for these patients. And how do you help them to go through pregnancy? Now there have been two people who have Pelkofer and Ringelstein. They have in separate case reports advocated that rituximab before conception and after delivery. During pregnancy, relapse rate is very less. So if you can give rituximab, patient gets pregnant, and after delivery, after 9 months, you give the next further dose of rituximab, then that helps them to go through pregnancy and delivery without any issues. What we need to remember is that newborn may have reduced CD20, may have CD20 depletion for 3 to 6 months whenever rituximab is given. The other special category is children. The youngest patient recorded is 16 months old. So ADEM can present commonly in aquaporin 4 negative patients also. The international criteria for diagnosis are same in children as the adults, what we discussed earlier. The immunomodulatory treatment is delayed many times. In children, many times the diagnosis is missed because they think it is just ADEM related to some viral illness. They do not think of that they are not tested for NMOSD, and these patients may have further relapses. So the diagnosis many times was delayed by almost 11 years or so. So suspicion should be there whenever a child presents with ADEM, maybe we should do the test. Now I'd like to show this young man who presented to us. Basically he had this, as you can see here the features, he presented with an encephalitic like illness with these hyperintensities that you see there. And his CSF showed a few cells, I think 25 cells or something. And he was found to have, he was investigated, he was found to be MOG positive, and he was treated with IV methylprednisolone first thing. Now after 2 or 3 doses of methylprednisolone, he developed severe psychosis. This was outside, not in our hospital. So he developed psychosis, so they stopped treatment. For almost 6 months he underwent treatment with psychiatrists. And he also complained of vision loss after that. So when he came to us, he was already on, he could not be given steroids because the relatives refused to give him steroids again. He was treated with MMF. There was not much response. And we thought this was his cord. So you can see that 3-segment cord lesion there. So we thought we should give him rituximab. During that first dose of rituximab, he developed some reaction related to infusion. Though he was quite okay with that, but within 2-3 days only he complained of difficulty in swallowing and nasal regurg, and this was his MRI. He had developed a new lesion. Now we probably it had nothing to do with rituximab, but because he had developed a new lesion, now we thought that rituximab may not be effective for acute. We gave him, we admitted him, we said, okay, if he develops psychosis, we'll see what happens. We thought probably it was that cerebritis itself that had caused some features earlier on, what he was describing. So we gave him methylprednisolone, nothing happened. There was no side effect. He improved, and after that, he refused to take rituximab again because of that first time reaction. So I put him on azathioprine, and he has been fine after that. All his vague complaints of pain in the neck and occipital region, his vision has improved, his swallowing improved almost immediately, and he is doing fine. So ultimately patients come to us, as I said yesterday also, they don't come to us with one typical syndrome. We have to take the whole picture into account and then decide what treatment we want to give. So in a nutshell, antibody negative NMOSD diagnostic criteria are defined as per the clinical and radiological findings. Both are essential. As you can see here in this diagram, aquaporin 4 positive is a large chunk of that disorder, and MOG is now a separate disorder, and there is that thin line in between which is aquaporin 4 negative NMOSD, and we might be able to diagnose what it is due to soon. So we need to differentiate these patients from MOG and MS as disease profile, and the search for the newer antibodies that may explain the aquaporin 4 negative NMOSD is still on. Thank you. Yeah. Shall I remove this?
Thank you, ma'am. I think the house is open for questions now.
So, yeah, hello. Is it working? Yeah, thank you. I think we had a very great session by all the eminent speakers. One comment on Dr. Satish Chandra's very extensive presentation, sir. Thank you very much. And one of the things which has not been validated till now, but is often spoken, is something called a central vein sign. They say that if there are demyelinating plaques, you may find within the plaque, but it is not still validated. It has not come in criteria. So that is one. And maybe you want to comment on that. And Dr. Mishra, once again, excellent, as expected. But one of the things which I wanted to clarify from you is that how do finally, all vegetarians do not take 2 liters of milk every day, and and most of the vegetarians are also not on supplements or anything. So how do they get it, their vitamin B12? One. And second is there something called false normal vitamin B12? Because I have heard in some lectures, even though B12 may be 500, 600, person may still be B12 deficient. So I'd like your comments.
So central vein, what Carlos asked, yesterday we discussed about. And he also mentioned that it is not 100%. But it is a good sign. And once you find central vein, that means it is definitely suggestive of multiple sclerosis. And it is found, I did look at the literature also, about the 153 series of cases, central vein was found in only 60% of cases. So that means 40% of the cases still doesn't have central vein. So it is a good indicator, but don't be carried away. Just want to, because I have a mic, I can complete that question to Mishra ji. Mishra ji, that B12 and the child with malnutrition, I was reminded about Dr. Chopra's work on PCM. I think Chopra and Binder Kaur from PGI, great work on protein calorie malnutrition, exactly looked like that child with B12. So what is important is early recognition in a child, especially the infant, the deficiency disorder, and once you recognize that, it is ably treatable. And that is what is very, very important. So keep a watch when you are talking about pediatric population, it is extremely important. And one other point is the bladder involvement is also very well known in B12. That is the one other issue. So we used to have cases of psychiatric manifestations and bladder involvement, and we were seeing in our hospital, some residents used to come and tell me that bladder is not known, sir, not known to occur in a case of nutritional disorder. How do you explain? And that is very, very important aspect. So don't be carried away that B12 also causes bladder injury.
Thank you for your questions. You see, B12 level 211 is reported in most of the labs as the cutoff point. But I don't think that we should only depend on the level, because people take B complex, people take supplements, and they may have. So we should look at the overall picture, look at the clinical picture, look at the sensory joint position sense evaluation, look at the reflexes, and more evidences will make you stronger about the diagnosis. Second is the surrogate marker, You can look at homocysteine. Homocysteine again, in isolation it may not be, but in the context it may be important. So if you've got low B12, borderline B12, but raised homocysteine, higher suspicion. Methylmalonic acid is not commonly done. Also look at MCV, reticulocyte count and all those things. So closer we have us, how strongly are you suspecting? More strongly you are suspecting, more carefully you look and more will be rewarded. Yes, many people have normal B12 levels. And, or many people, normal looking people also have low B12 level. Now what to do with that? Is it a pseudo level? Is it something else? Well, unless there is a clinical, I have told you the clinical manifestations can be so varied, so subtle. Anxiety, agitation, inability to concentrate, fatigueness. So all these things are there. Now you have to decide what you think and don't depend only on one pointer, look at the other things also. Bladder, Satish, thank you very much for pointing out. We have done a study on, I did not go for, because the topic was demyelination. We have done a study on neurodynamics in fetal deficiency, published in Neurology, and about 2/3 patients of subacute combined degeneration have bladder involvement. And in some patients, double incontinence, or retention, and neurodynamics shows varied changes. It may be spastic bladder, it may be retention abnormalities, it may be evolution abnormalities, multiple things are, and impotence. All these things are possible. So I think, we should keep that possibility in mind. Yes, many people who have normal levels and B12 syndrome. The patient which I showed you, the businessman, B12 level was 1400. But homocysteine was high, clinical syndrome was there, inverted V sign was there. So I think we have to see overall and how strongly are you suspecting that diagnosis. Yes, I am not in favor of giving blind treatment to every patient because then you don't know. If a patient has definitely B12 deficiency, you have to treat him lifelong, once a month injection. And what rightly you said that it is the genetic abnormality. What is the absorptive defect? What is the metabolic defect? At what level we don't know, and people have to investigate. I wanted to do this study, collected blood samples of 100 patients, but it could not be done. So I wish some younger person who's got energy and motivation takes it up. It will be worthwhile. Nobody has done it. So look at different polymorphs in genetic studies. Very hardly any lab is doing all these things. So it is a great need, and we got so much of patients. So we should investigate that. Thank you.
Any questions now?
Question to one comment and one small comment and one question to Dr. Satish. I think excellent cases are really, I think, eye-openers. So the primary CNS vasculitis, one actually now divides them into two subsets. One is where they are medium vessel vasculitis, where an angiography or a high-resolution vessel imaging will actually show. Even the biopsy will be negative. And it's the small vessel vasculitis where the angiography will be negative, and then here the meningeal biopsy will be positive. So actually one divides them into that. So meningeal biopsy may not be required for all these. And Sjogren, sir, like you mentioned, so how do we diagnose if it's an anti-SSO negative? And you said lip biopsy? Do we do lacrimal gland or?
Lip biopsy is to be done, even the corneal biopsy can be done.
Because standardly it was either lacrimal gland or a salivary gland.
But corneal biopsy or the lip biopsy. The lip biopsy is more yielding. That is what our pathologist has told. And it is just a scraping of the lip which will help in these cases. And this shows that very beautiful vasculitis, and this we can see even in the peripheral nerve also. These are the two places where nerve is involved. Otherwise, the best is lip.
Just a scraping, sir?
Yeah, that's what they say. HLA I have not done, it is only in the literature.
No, HLA will be for the Behcets. HLA is for Behcets. For Sjogren's, it is an anti-SSO antibody. If that is negative, then sir said, that there is a lip biopsy, because that is a new thing we have not, because lacrimal gland biopsy was being done, but lip I think is a new thing because it's very easy if it's a scraping. Behcets.
And that is very, very clear. And it is very useful in investigation, and we are now picking up more benefits in neurology.
If no questions, okay, I have two questions for Dr. U.K. Mishra. Sir, you showed one case with the mental retardation and then B12 deficiency, and patient got corrected after correction of vitamin B12. And you found that okay, there was a genetic component also, both parents were affected, but both parents they were asymptomatic. How do you explain that?
I don't know. I don't know why parents are asymptomatic and child is symptomatic. But, you know, it's all possible because many people have, you know, for example, infection may be there with any infection or any deficiency does not affect all. It's not a linear relationship. Some people may be affected, some are not affected. Some have got a better reserve, some are got a lesser reserve. So I think that is okay. And moreover, I don't know where who gave it to the child. He got it either from the mother or from the father. You know, so this is the problem. But yes, I agree with you. Clinically, both the parents were asymptomatic. We looked at them. We looked at clinical examination. Of course, we didn't do imaging, but we do the clinical examination, and B12 was low, homocysteine was high. So these are the things, you know, which have to be evaluated in larger number and seen more carefully, and greater awareness is to be raised. But I have no clear answer for your question.
So there's another question now. In clinical practice, we all see there are asymptomatic patients and symptomatic patients with a vitamin B12 deficiency. And one of your slides showed that there are Brahmin communities and Vaishyas communities.
Yeah.
And because I practice in Hyderabad, and then I see Muslim patients also with a low vitamin B12 but asymptomatic. And we see some patients who are symptomatic with vitamin B12 normal. Now this whole picture is confusing, and whether what to give in them and how do we explain?
You see, this is absolutely correct. What cohort we had in our study was Brahmins and Kayast. These, the Banya community, these are two group of people who are mainly vegetarian, and they were having, they constituted 90% of our group. We have also one or two few patients who are Muslims, and you know, our non-vegetarians are really not non-vegetarians. You know, they are for namesake non-vegetarian. They don't eat meat very regularly. They tell me also that, you know, once in a while we eat. We are not very regular. But besides that, you know, I personally do not think that it is much of a nutritional problem, because, you know, many of the, you know, high society people, many of the, you know, top level people also have low B12 deficiency syndromes, and they are mainly, I feel they are mainly genetic, and that is why it is a congregation into Banya and Brahmin community. So that is one thing. I think it needs more evaluation and more in-depth study, but I think your points are valid. Why some people with the low levels are apparently normal. Now this apparently normal may not be actually normal. You treat them and they may become better, or do their psychometry and see that their mentation is improved or their joint position has been improved or not. So I think these have to be seen. Yeah.
Just the nutrition, it may also due to the absorption. There is absorption defect also. You may take the vitamin B12, but it is not absorbed properly.
But they don't manifest.
That is the reason in those patients we need to have a gastroenterology consultation and even a biopsy. A biopsy is done usually. They will do a pyloric biopsy and look at it whether it is H. pylori infection, which we have seen also with a florid manifestation. Ably treatable. We can give the triple drug regime for 3 weeks and the pylori goes out. Patient also improves. That is very well known. So don't assume that it is only nutrition, because we are seeing even in Apollo patients having B12 deficiency. You know the class of patients we see. Most of the patients are well-to-do people, but still the B12 deficiency.
So I think
last
excellent cases, you know, and B12 manifestation. The only problem is nowadays everybody comes with a panel of blood tests, which includes B12, and everybody has, most 90% patients will come with a low B12 level. Now, how to correlate the symptoms, sir? Because you showed so many wonderful cases of B12 manifestations. It's very difficult now to correlate that everybody has a low B12 level.
I think your point is absolutely correct, you know, that we should not go to the level only. Look at the overall clinical picture. Cognitive, spinal cord, peripheral nerve, joint position abnormalities, Then if you are doubting homocysteine level, look at MCV level, and they will give you some pointers if there are. Yes, if the patient is totally asymptomatic, even then the question will be rising, that the so-called fatigue and exhaustion and lack of interest and so on, is it B12 or not? I mean, that question I cannot answer, but you know, that you keep in mind. And even the absorptive defects, sir, are not actually absorptive. They are also, I told you, megalin, cubulin, you know, the polymorphisms, maybe the genetic abnormalities, maybe they're in absorption also, and in the metabolism also. So these are very, very complicated things, cannot be straightforward linked. And the second thing is, you know, which I believe is, you know, what is your reserve? Now, if a highly intelligent person, Satish Chandra is there, even if he has B12 deficiency, it will not manifest. But a moderate person, you know, who is not that bright, you know, will, the story was of Stalin. Lenin, when he died, his autopsy was available when Russia disintegrated. And what they found, that there were lesions in the speech area. But he never manifested with speech abnormality because reserve was so good. He was a terrific speaker. So it did not manifest, you know. So the background reserve, what is the pre-morbid, you know, will also determine. It's a complicated thing, but we should not go to the B12 level. Go to the patient as such. Look at his behavioral, cognitive, and spinal cord and peripheral nerve, and hematological, if you think so.
Vineet, many people come with low B12, but many of them come with more than 2000.
Yeah, the last question to Dr. Suchita now. Madam, you saw, you showing us cases of brucella. I also saw some few cases of brucella from northern Karnataka. But how common is a body ache in all your cases there? How common is a body ache with all demyelinating or white matter lesions with a brucella? Body ache.
Body ache. They have, I've seen patients coming with radicular pains, meaning they complain about shoulder pains and pains in legs also. So radiculopathy is known with brucellosis. But this patient that I was telling you about was a cerebral symptom. She had headache.
Yeah, because predominantly in my cases, okay, they presented with a body ache. Their major cause was a body ache. They came to a clinic only because of acute deficit. And then when I asked them, their first complaint was a body ache first.
In fact,
so it's a quite common symptom.
There are a lot of people who come from Rajasthan and all in our setup. So there are a lot of people who are exposed to cattle, and they come with vague complaints of pain in the shoulders and upper back and things like that. Otherwise, we used to keep thinking that there is a lot of psychological element and calcium deficient, this, that. So I tried doing brucella for these patients, but that has not come positive. So maybe there's something more that we need to study.
Very common with the brucella. PO.
Yeah. Thank you.
Close the session.
Good,
Thank you.
First session. I want to invite Dr. Vineet Suri to hand over mementos to our speakers. And first, Dr. Satish Chandra, sir. One more today also, sir, because another good lecture today also. Yes.
I think yesterday, so usually we don't.
Thank you, sir. Next, Dr. Yugi Mishra, sir.
Thank you very much.
Dr. Sucheta. Thank you. Now we go to the next session, and in that Dr. Subhash Kaul has consented to take the talk because P. N. Ranjan sir could not come, and so his talk will be the first one. For that session, we have two chairpersons, and I thank Dr. Jaiswal sir and Dr. M.K. Singh. Both are leading famous neurologists of Twin Cities. So please take the chair, and then we'll start the next session.
Good morning. Now we come to the penultimate session, and we are shifting our focus to strokes now. And today for the first topic, we have the stroke specialist who is going to speak about ischemic strokes and antiplatelets. Dr. Subhash Kaul.
Thank you, chairpersons, Dr. M.K. Singh and Dr. Jaiswal. Sudhir, thank you very much for inviting me. In fact, I remember that about 25 years ago, there was a stroke meeting in Apollo, Delhi. Probably Vineet may not have even joined by that time. I think Vineet Kohli organized that. And I was very keen on attending. That's why I called them. And I said, who is the stroke specialist? Whom have you called? So somebody said, sir, Dr. Subhash Kaul. So I was only talking to them. So, but it was fun. I went and I only talked, although I wanted to know who is talking. So this time also, Sudhir told me come on Sunday. There's Dr. Ranjan's talk. I said, yeah, definitely I will come on Sunday. It's a free day. And once again, after 25 years, I'm only giving that talk. So we are missing Dr. P.N. Ranjan. I'm sure you are all expecting him. But I'll try to say what he would have said. And it's nice to have Vineet here. So Indraprasth Apollo is well represented here with Vineet. So antiplatelet agents we can never get away from. That is the core of stroke prevention. And we know that ischemic stroke occurs due to a block because of a clot. And it's nice to remember the clot can form on the arteries. It can form within the blood, or it can form in the heart. We can remember it by A, B, and C. And as far as cardiac and blood is concerned, you need oral anticoagulants. But when it is arteries, you need antiplatelet agents. And the reason for that is the clot composition. If you look at the clots in the heart, they are very rich in RBC and fibrin, and antiplatelets do not work on them. But if you take the arterial clots, they are made of platelets. They are called white clots. Therefore, for all arterial clots, thrombosis, you need antiplatelet agents. And what causes the formation of this clot by the platelets is the atherosclerotic plaque, which to begin with is smooth, small, but as the time goes on, they become rough, they become ulcerated, and it is the ulcerated plaque which is the stimulus for the platelets to aggregate together by a mechanism. And you can see that mechanism is because of the activation by the collagen or by the shear stress, simply by the injury, right? Injury to the circulating platelets, and that activates the thromboxane A2, which is produced from arachidonic acid, and thrombectin X2 comes out, and it's a big aggregant of the platelets. And at the same time, that is one mechanism. And the second one is also the activation leads to increase in the ADP, and ADP is like a glue. It causes a lot of stickiness, but this ADP comes out of the platelets and then once again acts on the receptors on the surface of the platelets. There are many kinds of receptors, but it acts on P2Y1, P2Y12, P2Y, so on and so forth. And these are the two main players, ADP and the thromboxane, which causes platelet aggregability. Therefore, based on that, we have got antiplatelet agent. Aspirin works on the thromboxane pathway, and clopidogrel works on the P2Y1, and ticagrelor also acts on another subset of P2Y12, basically interfering with the ADP stickiness of the platelets. So there is one more player in this, that is the vascular endothelium. Now this arachidonic acid is also present in the vascular endothelium, and this arachidonic acid produces PGI1, which is a vasodilator, right? So that basically causes separation, that is anti-aggregatory effect. So that also works on the platelets. And you know your celestazole and other, they are phosphodiesterase inhibitors. So therefore they increase the levels of the PGI2, cause vasodilatory effect, and also cause the anti-aggregation effect of the antiplatelets. So this is just a broad overview of the different mechanisms of these antiplatelet agents which are available. There are many of them are available, but the ones which are used in stroke are aspirin, clopidogrel, dipyridamole, ticagrelor, and also celestazole. So first we'll talk about the antiplatelet agent role in the primary prevention. It's a very hot topic, that before the stroke occurs, can you use it or not? And generally it's not favored very much, but the American College of Cardiology in its recent statement says that you might use low dose aspirin 75 milligram, might. It's not that you have to. You might consider it in patients who are having a atherosclerotic CVT among select adults 40 to 70 years of age. Which means there's a person who is having a coronary artery disease, peripheral arterial disease, diabetes, hypertension. You might consider. Most likely he will already be on aspirin because of this cardiac thing. But even if he is not, you might consider. But definitely here, more than 70 years, they want to be careful. It's only within 40 to 70. And the European Society of Cardiology suggests that among individuals at very high, not high, but at very high CVD risk, low dose aspirin may be considered for primary prevention. So the bottom line is you don't have to give it. If you don't give it, it's okay. Just reduce the risk factors of the patient without giving aspirin. But in certain cases, if the patient insists, family insists, relatives insist, and you feel, you might give a small dose, but be extremely careful if the person is above 70 years of age. This is for primary prevention. Now, one of the things which we commonly see in our practice are asymptomatic lacunes. The patient comes to you for headache or vertigo, and you do a CT scan, and there's 1 or 2 lacunes there, small vessel disease. What do you do about it? Well, this is the latest European guideline on covert cerebral small vessel disease, and it says we are against antiplatelet treatment in patients with small vessel disease. So in asymptomatic lacunes, no need to give as far as the recommendations are concerned. Expert consensus says we advise against the use of antiplatelet drugs to prevent clinical outcomes in patients with small vessel disease. Now, Dr. Mishra is here, and it's a very interesting study that Dr. Mishra has shown that you can use aspirin in patients of tubercular meningitis. That's a very common disease in our country, and many of them we see that they are having vasculitis. And I think this is an Indian disease. Nobody from the Western world will even be interested in this. So I'm very happy that Dr. Mishra gave us this concept that in a patient of TBM, we may use aspirin, but that is very local within our own situation. Now let's come to the mainstream after a stroke has happened for secondary stroke prevention. So clearly you can see that aspirin in a dose of 75 milligram is effective as 300 and even more effective than 300. That is sorted out, there's no question. This is the main antiplatelet agent, aspirin. Aspirin better than placebo. Now, what about clopidogrel? Well, clopidogrel also is compared to placebo, it's better. It gives you compared to aspirin, in fact, it is little more better, 7.3% extra relative risk reduction, but particularly in patients who are also having a peripheral arterial disease. So it's always a good idea when we see a stroke patient, also check all his pulses, including the pulses in his feet. Dr. Somaraj, our cardiologist in Hyderabad, says that always touch the peripheral pulses in the feet. Patient will be very happy that you are touching his feet. And at the same time, you will also get the information. And if there is a peripheral arterial disease, then clearly clopidogrel is a better choice, because in that subset it works better, provided the patient is not resistant to clopidogrel. We'll come to that. So those are two, aspirin, clopidogrel. Then the third player, those of you who are senior, you remember that about 15 years back, there was a lot of excitement about this combination of low dose aspirin 25 milligram and extended release dipyridamole 200 milligram twice a day. It was marketed as Agrinox in foreign countries and as Erino by same Intas company. And it was thought to be very good, and in fact it was thought to be better than aspirin or clopidogrel alone, as can be seen in this bar diagram. So it was clearly thought to be a winner. But the problem was that most of the patients, or many of the patients, could not tolerate it. They used to have splitting headache and all that thing, and we have gone through that phase. Then we used to tell them, okay, take one tablet for a few days till you get used to it, and after that, M.K. Singh is smiling because many of our patients have gone through this. Then there was a study in which all the, many neurologists from this country were involved. That was called PROFESS study. And here there was a head-to-head comparison between clopidogrel and this combination of aspirin and extended release dipyridamole. And it had other endpoints also. It used telmisartan for BP control and all. But this was also one of the arms of this study in the PROFESS study. And what they found is that there was no difference. It was not superior. Clopidogrel alone was as good as the combination. So that took away the crown from this Agrinox or Areno, and it said this single clopidogrel is as good, as effective as this combination, which we were giving to our patients and causing them headaches. So therefore, at that stage, which is about 15 years from now, we had these 3 drugs to be used, either aspirin alone, or clopidogrel alone, or this combination with more or less equal efficacy. And that's what the guidelines at that time said, that for non-cardioembolic strokes and who have no contraindication should receive antiplatelet therapy, grade 1 recommendation. Choice and dose of antiplatelet agent must balance risk of stroke against benefit, risk and cost of treatment. So you could have your pick, you could choose any one of these 3. But still the scientists did not leave this concept of double dose. They thought that if there are 2, they should act better. The combination should act better. Couple is always better than single. So they did not leave hope. Now they combined clopidogrel plus aspirin. And one of the most ambitious trials was MATCH trial. And you know, I like these trials because we have grown along with these trials. We have followed these trials. We have seen their successes and failures. This is our era, you know. So it was found that this combination was definitely superior, but it was negated by the high brain hemorrhages. But interestingly, those hemorrhages happened after 3 months. Within first 3 months, the hemorrhages were less, not as much. But after 3 months, it was just negated their efficacy because of the hemorrhages. So therefore, MATCH was thought to be a negative trial. And this double antiplatelet thing again could not find favor at that time. But it was also realized by scientists and observed that, you see, maximum recurrence in stroke occurs in the first 3 months. In fact, in the first 1 month, because that is the time when the endothelium is on fire. Don't we notice that when the TIAs happen within 1 month. After that, they stop happening as if nothing had happened. That is the stroke-prone stage. At that time, the endothelium is on fire. Once everything settles down and if patient takes care of his risk factors, and then it doesn't happen. So first 3 months are very important. That is the concept of giving antiplatelet agents for at least double antiplatelet agents, at least for the first 1 month or first 3 months. That was the concept. And so it was thought that which of the stroke subtypes they should choose. And the first trial which was done at that time, this is 2010, 2011, was a trial which was addressed at intracranial atherosclerosis. And you can see this is the intracranial atherosclerosis where you see large arteries are blocked. We already had solution for the extracranial atherosclerosis. We knew that these have to be endarterectomized or they have to put stent. But we did not have an answer about the intracranial. There is a very good article in Neurology, 50 years of uncertainty of intracranial disease. We will know that Louis Kaplan used to give anticoagulants in these patients for years and years. Anticoagulants, acetram, I'm guessing also used to give. I know it for sure. So they said, let us start with this intracranial disease. In Hyderabad, we had a stroke registry for 10 years. We assiduously collected data and we found 30% of our patients have intracranial disease. And that is the experience all over the country. Now it's called ICAD. You know, all the interventionalists use that term, ICAD. So for this, the trial was done Samipris, where they compared stenting versus double antiplatelets with high-dose statin with exercise, quite a strenuous exercise. And what they found is that double antiplatelets, aspirin plus clopidogrel, was far better than the stenting in terms of efficacy, in terms of lack of side effects. And that is where the first concept that you can give double antiplatelets for 3 months, followed by single antiplatelet. This is how the roots of that concept came, that for intracranial disease, you can give for 3 months along with the other things. But soon later, another study, Chinese study came, it's called Chan studies. So they gave double antiplatelets only for 21 days. And they found that there was a clear difference between the, between the ones who had received single and compared to those who had received double. The early recurrence was much less in the double antiplatelets, almost with the same design. The chance was replicated in the non-Chinese centers in US and Canada and all, and that was called POINT trial. The only difference here was that they used a higher dose of clopidogrel loading. They used 600 mg. In the chance they had used 300 mg. Here they used 600 mg, and they continued it for 90 days, right? And they also found that there is a good result. So now we had got 2 trials. Both had given early antiplatelet. In one they gave for 21 days and in one they gave for 3 months. And in both they found that there was a substantial decrease in the early recurrence. So Dr. Kameshwar Prasad, he is a known person of doing meta-analysis and epidemiological. So he studied all this subject, and finally this is a publication in BMG in which he said that dual antiplatelet therapy with aspirin and clopidogrel for acute high-risk transient ischemic attacks and minor ischemic stroke should be a clinical practice guideline. And he suggested only for 3 weeks you should give it, because after that there is a risk of hemorrhage. Now, one point I want to emphasize here, we should not indiscriminately give this double antiplatelet. It's only for minor strokes. We should remember, minor non-thrombolized strokes. And these days minor strokes are 3 or less than 3. So it's only for minor strokes, it's for non-thrombolized strokes, or it's for TIAs. It's not for everybody. We should remember that. So in nutshell now, if we are giving double antiplatelets, what should be the duration? If we have documented intracranial athero, we can give up to 3 months. If it's extracranial athero, either you stent him. If you have stent him, anyway you will be giving him double antiplatelet. But if you have not stented him, then by extrapolation you may give for 3 months, and later on you can go. For aortic arch athero, please remember aortic arch athero also is a large artery. Large artery starts from the aorta. It's not a cardiac. It should not be called cardioembolic. It's a large artery. There also you give for 3 months. But in all others, in lacunar strokes, we should stop after 3 weeks. And in stroke of unknown etiology also, we should give it only for 3 weeks, double antiplatelet. And then we should go to single antiplatelet. And that makes sense. There is a lot of literature where it is shown that lacunar strokes are prone to bleed later on. This is one of my own patients who had a thalamic bleed, and few weeks before that he had a infarct, lacunar infarct. So in lacunar infarct, we should not give double antiplatelets, and this has now come in our guidelines also. So what is the recommendation for long term after 3 months? After 3 months or 3 weeks, you have given double antiplatelets. What do you do after that? After that, it's your choice. You can either put him on aspirin, or you can put him on clopidogrel, or you can give him extended release aspirin. It's your choice, one of the 3, right? But if the patient has peripheral arterial disease, then it is better you give him clopidogrel. If the patient is allergic to aspirin, I have not seen any person allergic to aspirin so far, but you may have seen, but they often talk that if he's allergic to aspirin, then you give clopidogrel. And of course, clopidogrel is expensive compared to aspirin. Some people may have financial problems, then for that aspirin is recommended. Now, what if antiplatelet drugs fails? I think Vineet Suri may remember you had given me a talk on this in your conference when you organized in Delhi, that how do you deal with the antiplatelet failure? So that time I reviewed this literature, that your patient is on single or double antiplatelet, and in spite of that he has a stroke. So most important thing of failure of antiplatelet is your patient is not taking it. You'll be surprised, in our registry 50% of the recurrences, the patients had stopped taking it. They stopped coming to the doctor. They thought, now I am well. So patients are like small children. They are like kids. You have to be like teachers. You have to constantly remind them, call them for follow-up. Are you taking it or not? They are doing a trial, sprint trial, in which on mobile they are reminding them. Are you taking it or not? Patients stop, right? They are human beings. Look for pentoside or NSAIDs. They also interfere in the absorption of these ecosprin. And then sometimes they may not be working. You can do platelet aggregometry for this, which is called TEG, if your patient has a recurrence, and see whether the compound is working or not. Both aspirin as well as clopidogrel resistances are known, but clopidogrel resistance is much more common. And look for any other mechanism. We may be thinking our patient is having an arterial stroke, and yet there may be a patent foramen ovale inside. Yet there may be a, enlarged left atrium. There may be a mitral stenosis there. So we should look for another mechanism if the platelet is failing. And of course, check for resistance. And we have to know that clopidogrel is a prodrug. When we give clopidogrel to a person, it has to go to the liver through a hepatic P450 pathways. It has to get activated, and then it has to cause its active form, right? So some people have got a polymorphism of this cytochrome pathway. So therefore, that's called loss of function allele. Loss of function allele, because it is not getting converted because of the polymorphism in the liver. So therefore, clopidogrel is ineffective. And it is found at least 30% of the Indian studies whichever are done. There is one done in Gangaram by Chandrasekhar from India, and we are also doing currently. So in Southeast Asia, it is thought about 30 to 40% of patients. But in India, whatever studies are there, 30% of. That's why cardiologists have practically stopped using clopidogrel. They are now using only ticagrelor. because it is so common, particularly if the patient is stented and all and then he gets thrombosed. So this is the problem with clopidogrel. Otherwise, it's a good drug. This is one of my own patients, recurrent stroke, 4th time, small acute infarct in left pericentral in spite of double antiplatelets. So what I did is that I put him on Erino. That time I thought Erino is that combination of dipyridamole, but he got severe headache with that. So I had to stop that also. And then this patient, I got his clopidogrel resistance done, and it was resistant in that patient. It was found that the patient is having a heterozygous intermediate metabolism. And so therefore, I had to put him on ticagrelor. And since last couple of years, he is not having any recurrence at all. And in fact, this data came in 2020 from a Thalys trial. It's a Thalys trial. This is the latest in the antiplatelet strategy. And what they did in that trial is that in patients who are having stroke and with mild intracranial disease, which means 30% or so obstruction in these vessels, they give 90 milligram ticagrelor twice a day plus aspirin. But aspirin should not exceed 100 mg. That's very important. It has to. So in our setting, it is 75 mg. So 90 milligram after a loading dose of 180, then you give 90 milligram twice a day plus aspirin 75 mg, but it's to be given only for 1 month. That we have to remember. Now, why it is 1 month? Because in that trial it was done for 1 month. Sometimes in our practice we may little exceed also, but guidelines, if you go strictly, then after 1 month you have to stop it. And then you have to give him either a single antiplatelet or choose some other antiplatelet. Now, the advantage of ticagrelor, it's almost like clopidogrel. There is no difference. It works on the same receptor, same set of receptors, but the difference is it doesn't have to go through liver. It directly goes to the platelets, as you can see in this picture. This is ticagrelor, it's going, there is no in vivo biotransformation, it directly goes to the liver. Whereas our clopidogrel, unfortunately, has to go through liver, where 30% of the times it is not converted into its active metabolite. So that is the main advantage of using ticagrelor, or, it has various names by various companies, Brilinta, Anticastro, and so on and so forth. Now, what about silestazole? Silestazole is a medicine which is used in Korea, in Japan, and it is thought to be a very good drug in these patients. There are very nice studies and systemic reviews for secondary prevention of stroke and cognitive decline. It's a phosphodiesterase 3 inhibitor, widely used in Asia Pacific countries. And in addition to the weak antiplatelet effect, it also has a mild vasodilatory and endothelium repairing effect. And most of the studies have shown that it is bleeding complication is less compared to the other antiplatelet agents. And there were 2 very good trials. If you look at them, I have studied these trials, CSPS1 and CSPS2. And in that, they have taken resistant patients who have been having recurrent strokes, and they have had 3 arms. They have combined silestazole with aspirin or silestazole with clopidogrel and given it at least for 2 years. So this one month restriction or 3 months restriction is not there. It was given for 2 years in both these trials, and it was given more so where there was a high risk of brain infarct as well as brain hemorrhage, and it was shown very good results compared to the other combinations. And in fact, from a personal experience also, that's my experience in patients who do not tolerate other drugs. I have used it, silestazole, and many of my friends I have discussed, and they also use it from time to time, but not indiscriminately. It's very expensive. Some of my patients say it's very expensive, they cannot afford to take it, so I had to stop it. So therefore, what we are saying now basically is that in any stroke, if it's a lacunar stroke, then you give only aspirin or one of the single antiplatelets. But if it's a large artery disease, then you can give for 3 months or so, depending upon whichever drug the patient can afford. So this is the latest American Stroke Association guidelines, and we have got now this range of antiplatelets. Most important recommendation is that at least they have to get aspirin. That is for sure, right? And if the TIA is caused by 50 to 99% stenosis, grade 1 recommendation is you can give aspirin. You can give aspirin alone. You will not be wrong in that. That is grade 1 recommendation. Please remember that. It's not that we have to give double antiplatelet. Grade 1 recommendation is that you have to give aspirin. But if you want to be a little more effective, then you can add clopidogrel to it, 75 milligram per day up to 90 days. We are talking here only about the intracranial atherosclerosis, not about lacunes and all. There we have to give only one antiplatelet. Or we can give 2 antiplatelets for 3 weeks, right? But we are now talking of the intracranial disease, which is most commonness. So either give aspirin alone, or you can combine aspirin with clopidogrel only up to 90 days. And then your third choice is, which is the latest, that you can add ticagrelor to aspirin. And this you have to give only for 1 month. And after that you have to stop it. 30 days is there, not after 30 days. And the last one, and it's a very happy situation, that celestazol has been brought into American recommendations also. Usually Americans are very reluctant to put drugs from other countries into their guidelines, but it has been brought, and it clearly says that in patients with stroke or TIA, attributable to 50% or more stenosis of a major intracranial artery, addition of celestazol 200 milligram per day to aspirin or clopidogrel might be considered to reduce recurrent stroke rate. Of course, it's a 2B recommendation, which is not a very strong recommendation, but it is an option. Now, these options we take in difficult patients. They are not routinely to be done in all the patients. They are no routine, those difficult, frustrating patients who keep on getting stroke after stroke. So this is one option which we are having. And the last thing which is very exciting is that there is a trial called COMPASS trial, in which they have used low-dose rivaroxaban with aspirin, 2.5 milligram rivaroxaban twice a day plus aspirin 75 milligrams. This has been used in patients who are having a stable arterial disease, peripheral arterial disease, carotid arterial disease, coronary artery disease. So there's a man who has a long, myocardial infarction few years ago, and there's a peripheral arterial disease, or there's a 40%, 50% carotid disease, and he's stable, he's asymptomatic. This trial took those patients, and they are giving aspirin plus low-dose rivaroxaban. Normally, I would not give it to anybody, if aspirin alone is working, but it is an option. Suppose a patient has had one attack, one TIA, in spite of aspirin, then I can put him on this combination and hope for the best. So, but do not take antiplatelet drugs for granted. Don't think they are safe. So whenever you are giving antiplatelet agent, make sure that he should not take alcohol, and even if he is taking it, he should take it within limits. And second is that avoid double antiplatelet drugs, and definitely avoid triple antiplatelet drugs. I have myself used triple antiplatelet drugs, sometimes till I had to burn my fingers once or twice, because this is what can happen. This is not oral anticoagulant, this is a triple antiplatelet agent only, and this is what he got. So they are not benign drugs, so we have to use them very, very cautiously. So this is the summary, that even today, aspirin remains the crown jewel of antiplatelet treatment. This is number 1 and continues to be number 1. We may add clopidogrel for 21 days in all strokes. We are talking of non-cardioembolic strokes. Cardioembolic is a different game, but we may add. But there should be small strokes, I should emphasize. There should be non-thrombolyzed TIAs or mini strokes. But if there is an intracranial atherosclerosis, you can extend this double antiplatelets for 3 months. But after that, go back to single. Ticagrelor plus 75 milligram aspirin for 1 month is an option. And that option you may take in some patients. For instance, I take that option when my patient has, in spite of double antiplatelets, he comes with a TIA. So obviously, there's no point of using clopidogrel. Then I switch him to ticagrelor. But I think today we are in a stage where we can, to begin with, only put them on ticagrelor and aspirin, and later on take it out. And of course, there are some patients who keep on stroking, and you know that you want to give something for a longer duration. 30 days is not enough, 3 months is not enough. In that scenario, celestazol can be given, because in the clinical trials it has been given for 2 years or more. So this combination we can give, but it will be costly for the patient, that's okay. So in summary, development and use of drugs is a journey. It's an evolving journey. By next year we'll have more data. By after 2 years we'll have more data. But the good thing is that we are all together in this journey. We study together, we learn together, we practice together. Thank you very much. Questions at the end of the session? Oh.
I think it's always mesmerizing to hear Dr. Kaur. He makes such a difficult topic so simple, and it's we get hypnotized when he talks.
We learn from you, Vinny.
No.
Most of the guidelines I learned from
I
you.
think the, one comment, about antiplatelets. I was sitting with a neurosurgeon in a talk, and they started on antiplatelets, and he walked out. So I said, why are you walking out? He said, neurologists are only going to fight on the dose, whether it's 75 milligram. We are doers. We'll go and operate. And
it's called aspirin war.
Neurologists are only going to talk about, whether it's good in females, whether it's good in males, whether it is what dose. So that's apart from that. But what happens is, I think the problem that happens is that most of the guidelines suggest only do 3 months for dual antiplatelet, only for minor stroke and TIA. We are actually more bothered about the intracranial stenosis, ICADs. So he has a M1 occlusion, and he's got a moderate stroke. And we are more worried that he's going to come back. So we are going actually beyond guidelines and giving him dual antiplatelet. That's the patient where we want to give. Somebody who has come with a TIA and he's got normal vessels, we don't want to use the dual. We want to use the dual when it's an M1 occlusion, when it's an M2 occlusion, when he's got very bad vessels, we want to give dual. So I think sometimes the cardiologist come to our rescue because he also has a cardiology issue. And the cardiologist is giving him dual antiplatelets, and we say, okay, it's good for the heart, so let's continue, so we can continue. Yeah. Very often, the cardiologist is using 150 milligram of clopidogrel because he's stented the patient. Now that becomes a problem for us. Patient comes to us and he says, doctor, you kindly write what I have to take. Now the cardiologist has given 150 milligram of clopidogrel with 150 aspirin. And I have to also give the prescription. Patient says, sir, you write the final treatment. What do? We cannot. For us, the guidelines don't permit us. Even though we know that for the stent, at least for 3 months, he needs dual, he needs a double clopidogrel. So it's a very tough issue. Using dual antiplatelets in situations where we cannot, cardiologists using dual antiplatelets. So I think we tailor make it for us. We say,
Correct.
okay, let the cardiologist use what he's doing. And I think we use it like that. But I think in some situations, the COMPASS trial, which also had a 24% reduction of stroke, can be used. So when we have a very difficult situation, even double antiplatelets have failed, even using rivaroxaban and ecosprin,
we can do that.
Is a good escape, where double antiplatelets. So patient is on aspirin and clopidogrel, he's failing. So, and ticagrelor, the Thales trial says only 1 month.
Yeah.
What do we do after 1 month?
Correct.
We can't get him back onto aspirin. So I think there we have some literature that we can use, rivaroxaban along with, although I have not tried, but I think that is the escape.
Absolutely, yeah, you're right. You're right. You see, we have to remember that, Vineet, what you correctly said, I have in fact once heard a lecture, it said guidelines are guidelines. Guidelines are not God lines. God has not written them. They are guidelines. Finally, we have to keep our safety of patient and the particular situation, as you rightly said. In fact, Vineet Rohit is now doing one trial from ICMR for extended double antiplatelets for 1 year of this clopidogrel. Some of our patients are on that because of cardiologist requirement. I completely agree with you, sir. Yes, he's neurosurgeon.
Neurosurgeons don't walk away, sir. We are very scared of the aspirin and clopidogrel. And there's one thing, sir.
Yeah.
The general physicians, just because a person has hypercholesterolemia, they put them on Atorva Fit CV, let us say. The patient is there for the last 15 years. He's for surgery next week. So I asked him why. He said, no, the doctor said. I said, do you have a heart attack? Did you have a brain stroke? No, nothing. He's been on this for the last 15 years.
Yeah.
So that's why we are very scared of it.
Yeah, that's right.
Primary prevention, like Dr. Paul very rightly mentioned. See, the guidelines are that for primary prevention, if you use aspirin, it reduces the risk of cardiac. It reduces the risk of myocardial infarction, but that is negated by intracranial hemorrhage. So for primary prevention, it is not recommended. Diabetes, the Diabetes Society mentions that if you have a diabetic patient, then aspirin reduces the cardiac risk. So I think in a diabetic patient, there is now some recommendation that you can use aspirin and a statin as a primary prevention.
You see, the problem was that in America, everything is driven by America. Everything. is driven by America. They drive whether our food, Kentucky chicken, McDonald's, aspirin, baby aspirin, these are all American terms. It had become a habit to take baby aspirin. Oh, I'm taking baby aspirin. So it was found over the longitudinal studies, those baby aspirin, in many of them are causing intracranial bleeds. Same is true about carotid endarterectomies. In 50s, every American used to have a carotid endarterectomy till that NASAT trial came and stopped it. So this is to put a stop to that indiscriminate use of aspirin. But there are some situations where you can use it with very cautiously. In fact, there is a website of American Stroke Association which they have given a pro forma where you can put your age, your risk factors and all. They'll tell you what is your 10-year risk of stroke, and then they will tell you whether you need a 75 milligram of aspirin. So as a general rule, not to give, but in some situations you may give. So are we done?
Are there any more questions? Thank you for that excellent introduction, Subhash.
Thank you.
Now I invite Dr. Suryanarayan Sharma. He is a neurologist from Bangalore to give his talk.
Pointer is there. Yeah. Good afternoon. At the outset, I thank Dr. Sudhir and his team for inviting me to deliver a lecture on anticoagulation induced ICH. I'll show you initially some of the case vignettes, then probably we will discuss one by one. This is a 52-year-old gentleman. He is a case of, he's a hypertensive, non-diabetic. He is a case of rheumatic heart disease with mitral stenosis, and he was on 4 milligrams of warfarin. So he presented with sudden onset headache for 6 hours, and he had one episode of seizure. This is the CT scan finding. So basically he has a mixed hyperdensity lesion in the right parotoccipital region, and also there is a mass effect and the ventricles are effaced. So the next case, this is a 61-year-old lady on warfarin for non-valvular AF, presented with fever and thrombocytopenia, and this is the CT scan what we got. So basically the primary site of the bleed was a thalomocapsular region with intraventricular extension with mass effect, and even you can see the EVD in situ, and this patient had a prolonged course, and in spite of the best medical management and surgical management, she didn't survive. She committed, she died after 3 weeks of ICU care. The third patient, 45-year-old lady, 45-year-old gentleman, CLD with portal vein thrombosis, started on warfarin since 2 weeks. He was found unresponsive in the bathroom, and this is the CT scan what we got immediately at the emergency. There is a cerebellar bleed. The most characteristic feature of a anticoagulation induced bleed is, one is it's a heterogeneously hyperintense lesion with air fluid levels, multiple, it's a irregular bleed. It is not like a typical thalamic or a putaminal bleed what we see in a hypertensive case, wherein it's a well organized clot what we see in most of the hypertensive bleeds. So in anticoagulation induced bleed, what we see is largely a air fluid level, blood fluid level, and also the irregularity. So this is another case. So I am just putting the example of a leech therapy, because leech, what it does is it secretes in the saliva, it secretes hirudin. So that prevents coagulating, that prevents the blood from coagulating. So painlessly it sucks the blood. So you can think that that patient with anticoagulation induced bleed, many a time they are not very acute in presentation. They may be even subacute in presentation. So this is my own paper in 2015 in Indian Journal of Neurotrauma. A patient, this is a 56-year-old gentleman, CLD, ethanol, chronic ethanol abuse. He had a seizure and fall actually. So this is a CT scan of his. What you can see here, he has a subdural, he has a subarachnoid, he has an intraparenchymal, and he has bleed in different planes, what you can see. At the same time, there is no fracture anywhere in the calvaria. So to cause a impact, suppose if you see patient had a seizure and fall, to say that okay, it's a traumatic brain injury, there is no fracture anywhere. To cause this much of impact, invariably they should have had a fracture. And there is no CVT, angiogram is normal. So this patient underwent a left frontotemporal decompression craniectomy and evacuation of hematoma, and after 2 weeks, he was discharged. So this is, though it is not directly related to anticoagulation induced ICH, when cardiologists started using ticagrelor as a first line drug way back in 2013, I think many of my colleagues across the country would have seen a lot of spontaneous subdural hematomas. With ticagrelor. So, and even we had seen intramuscular hematomas, with compartment syndrome and all that with ticagrelor. So this is a ticagrelor induced spontaneous subdural hematoma, but we didn't do any surgery or anything, we just stabilized the patient with best medical management. So this is the discussion what we had written in that journal in 2015. Now let's come to the anticoagulation associated intracerebral hemorrhage. So what is the epidemiology? Vitamin K antagonist versus NOACs, anticoagulation monitoring, how to manage, when to restart anticoagulation, and what are the future trends. So usually if you see oral anticoagulation associated intracerebral hemorrhage in different studies account for close to 20% of ICH. So annual risk of ICH in oral anticoagulation therapy is said to be 0.25 to 1%, but it is almost, I would say, 7 to 10 times that of a general population. So oral anticoagulation, what is the main reason why the patient bleeds? So it is not that it will trigger a acute ICH by itself, but number one, it increases the extent of the parenchymal bleeding and the vessel rupture. Once the vessel rupture has occurred, suppose the most important trigger in this is the uncontrolled hypertension or inadequately or improperly monitored blood pressure in most of the patients. Many centers, what we do is we monitor PT INR very judiciously. At the same time, many a time we may not be focusing much on the blood pressure variations of the patient. Suppose he may come back after 2 weeks with a bleed, but in that most of the PT INRs in our anticoagulation induced bleeds were less than 3. So that indicates that hypertension is a very important cause which has been often missed. So what are the characteristics of anticoagulation induced ICH? One is ICH expansion is more common, almost up to 54%. It is delayed. So the hematoma expansion it may not stop at the 2 or 3 days. There may be a delayed effect. And usually, the higher incidence and extent of intraventricular bleed. So patient's morbidity is more, poor outcome. Then location, usually a higher incidence of lobar and cerebellar bleedings, especially INR more than 3. Appearance on baseline NCCT. Whenever you do a CT brain plane and CT brain plane, and usually they are all extremely irregular in shape. There will be blood fluid levels. They usually reflect the abnormal coagulation of the parenchymal blood. The neuroimaging predictors of active bleeding, such as the CT angiography spot sign, the irregular CT hyperdensities are significantly common, and indirectly they confirm that possibly there is a coagulation defect and the hematoma is likely to expand. So these are all the common risk factors for oral anticoagulation induced ICH. Age more than 70 years, INR more than 4, but I am sure most of us see INRs within normal limits when patient presents with, ICH. It may not be a acute or a catastrophic presentation in many patients. Usually they will have some kind of a dull headache, chronic headache. Sometimes they become totally dull. Sodium may be done. Sodium may be 129 or 128. We may attribute it to hyponatremia. Even you correct hyponatremia, patients are still down. You do a CT, you may find a subdural. So this is the usual typical presentation of a anticoagulation-induced intracerebral hemorrhage. Drugs, they may have concurrent antiplatelet therapy. Genetic, ApoE2 and ApoE4 allele, these two subtypes, they are more prone to develop ICH. So in patients, especially if you suspect, or if the patient already had a anticoagulation-induced ICH, it's worth doing the genetic genotype. So the annual rates for ICH in NOACs. Now let's come to the NOACs. It is 0.23 to 0.5%. NOACs are safer compared to vitamin K antagonists. I think yesterday Dr. Vineet Sori showed in the slide the 51% reduction in intracerebral bleed compared to conventional anticoagulation. So that's a huge advantage what we had. The prospective registry of that is the Rasunoya that showed hematoma expansion is frequent in patients with NOACs. It has a higher mortality and unfavorable outcome among the survivors. So now just to show what are the different anticoagulations and anticoagulants and antiplatelets and the time of onset, I will just restrict to the anticoagulant part. Heparin 3 to 4 hours, we have an antidote that is protamine sulfate, immediate reversal. Low molecular weight heparin 12 to 24 hours. Protamine, it may have a partial, I wouldn't say complete, but definitely it's a partial one. So then vitamin K antagonist, warfarin 60 to 80 hours, 3 days. So vitamin K IV, vitamin K oral, then PCCs 12 to 16 hours. The recovery is 12 to 16 hours and in 24 hours. If you give PCC, it's immediate. So I think Dr. Dr. Sudhir will give a lecture on the PCCs. Then direct thrombin inhibitors like dabigatran, rivaroxaban, apixaban. I'll come to the treatment details, in the coming slides. So how does warfarin act? Warfarin act by antagonizing the antihemorrhagic effect of vitamin K. It inhibits the hepatic synthesis of vitamin K dependent coagulation factors. So vitamin K is a very essential cofactor for post-translational carboxylation of glutamate residues on the N terminus of the vitamin K dependent proteins. So other anticoagulants, usually warfarin and acinocumarol. So as I said previously, it inhibits the production of active clotting factors. It gets absorbed very rapidly, binds to albumin. Clearance is little slow. Usually it takes 36 hours. That is a problem whenever we have an emergency situation. Patient comes with a hip fracture. The orthopedician is sitting on our head to reverse it immediately. Or patient comes with a GI bleed or a acute abdomen wherein surgeon wants to open. And that's where, we need to reverse the effect of anticoagulation. So absorption, both are rapid and complete. PCAR 2 to 3 hours and warfarin within 4 hours. Protein bound, both are protein bound. Half-life is 10.9 hours in acinocumarol and warfarin has much longer half-life. And even, the elimination, if you see the renal elimination in 60%, warfarin is 92% renal clearance. Heparin versus warfarin. Heparin activates antithrombin. Warfarin, I already, discussed. The duration, both are, heparin is brief. It is best for the emergency setting. In ICU or critical care setting, best is to give plain heparin wherever there is a doubt. So coming to the newer oral anticoagulation, dabigatran, most widely, studied oral anticoagulation. Now apixaban, rivaroxaban, edoxaban, all others have come. Apixaban, if you see the efficacy, among all four, dabigatran has the best efficacy. If you see the safety profile, apixaban is the safest. So whenever whenever you are choosing the anticoagulation for your patient, you need to see whether what is your therapeutic endpoint. If patient has a CLD, if patient has, renal failure, patient has a renal failure, dialysis patient, you are going to use apixaban. So you have to choose the patient, you have to choose the drug based on your patient requirement. So advantages of NOACs over vitamin K antagonist is that NOACs can be administered in fixed dose. You don't have to, one is you don't have to monitor the anticoagulation, and it is not body weight dependent. You don't have to either it's dabigatran is available 150 twice a day, or 110 twice a day, or 75 twice a day. Only three doses are available. Apixaban 5 mg twice a day. So if patient is like 130 kgs, many a time it may not be helpful. So you have to look at all the possible ways before administering NOACs to the given patient. Routine drugs, routine anticoagulation tests like APTT, PTINR do not correlate well with NOACs. It has a much shorter half-life. Coagulation test interpretation depends on the time of last dose, possible interaction, kidney and hepatic functions. And NOAC anticoagulation level monitoring needs special tests. So how do you monitor? So we need a point of care testing for anticoagulation. So one is you need to have a CoguCheck like our glucometer machines, wherein you can see the PT-INR for vitamin K monitoring. Then hemocron signature is used to qualitatively rule out relevant concentrations of rivaroxaban and dabigatran. So whenever you are doing anticoagulation monitoring, number one, PT, APTT, INR. PT, APTT, INR can be measured for vitamin K antagonist. But when you are using dabigatran, APTT, moderate to high dabigatran concentrations induces significant change in APTT. INR is not affected. So keep a APTT watch. But APTT is not sensitive enough to detect the presence of meaningful anticoagulant activity. Suppose if APTT is normal, it doesn't say that there is a meaningful anticoagulant activity. So the prolonged APTT reflects the presence of significant anticoagulation, whereas normal values do not rule out the presence of coagulopathy. If APTT is normal, patient is bleeding, there is a ICH, APTT is normal, but treat the patient. That may not correlate directly with your patient. So here, if you see the saccharin, the dabigatran concentration and the diluted thrombin time, DTT. So DTT is a gold standard test for evaluation of evaluating the plasma levels of dabigatran. So reversal should be considered when blood level is above 30 nanogram per ml. Another thing is about hecarin based coagulation testing. So hecarin clotting time, ECT, is another sensitive and reliable test to estimate the blood concentration of dabigatran. So using a calibration curve, DTT and ECT can accurately quantify the circulating concentration of dabigatran. So whenever you are in doubt, you do both. You can inform your biochemist so that they do both the DTT and ECT. So another thing what they do is chromogenic anti-factor 10A assays. So absent chromogenic anti-10A assay usually rules out clinically relevant levels of the drug, factor 10A inhibitors. So this is what we usually do, APTT for dabigatran, PT and PT for rivaroxaban. And in case, whenever we feel, we may have to do all other factor 10A activity, anti-10A and other things. So coming to the treatment, how do we treat these patients? Most important, the general treatment of NOAC-induced ICH doesn't differ much. The basic supportive measures and other things remain the same as compared to spontaneous ICH. So the data from a larger observational study that suggested INR less than 1.3 with a BP control. I'm telling both BP systolic blood pressure in any of these anticoagulation related ICH, it should be less than 150 or 160 milligrams, 160 mmHg. It reduces the risk of ICH expansion in vitamin K antagonist associated ICH over 4 hours. The latest meta-analysis demonstrates significant prevention of hematoma expansion if BP is less than 140. So whenever patient comes with a anticoagulant, probable anticoagulant associated ICH, most important one is bring down the PT-INR to less than 1.3, control blood pressure. So if you do these two, then you may avoid a surgical intervention sometimes. So attention to comorbidities. If patient has a thrombocytopenia, patient may have a uremia, patient have a liver disease, patient may be on dialysis, all that you have to keep in mind whenever you are treating these patients. So vitamin K antagonist reversal, I think Dr. Sudhir will tell in his next talk, so I'll skip this. So only most important thing is stop vitamin K antagonist, administer vitamin K IV. Then dabigatran reversal, we have a good dose, a good drug now. Administer idarucizumab 5 grams, that is 2 doses, 2.5 into 2 doses. If idarucizumab not available, you can give 4-factor PCC. You can go up to 25 to 50 units per kg. Then if that is also not available, activated charcoal 50 grams if last intake is less than 2 hours. So it will reduce the absorption of dabigatran. And dabigatran sometimes, because 2/3 is not protein bound, it is free drug. Only 1/3 is protein bound. So you do dialysis, sometimes you may reduce the dabigatran, especially if patient is already on dialysis, impaired renal function, you can consider doing one sitting of hemodialysis. The reverse AD trial. Reverse AD trial is reversal of dabigatran effect with idarucizumab. So usually this the primary endpoint was maximum reversal of anticoagulant effect, which was assessed by DTT or ECT. The primary endpoint was reached in almost all patients, 100%, and reversal was usually maintained for 24 hours in most of the patients, and the treatment was quite safe with no significant adverse effect. The mortality rate was 30-day mortality was 16.4%. So the another thing is about reversal for factor 10A inhibitors. Andronicet alpha, that is the antidote, it's a reversal agent that is designed to neutralize the anticoagulation effect of both direct and indirect factor 10A inhibitors. So this from US FDA has approved from May 2018. So in India also, I think some centers now they are getting the drug. Though I have not used, if anybody has used, probably you can share your experience. So how does it act? Usually factor 10A is that. Andronicet alpha is a decoy kind of a factor 10A. Basically, the structurally similar, so it gets bound to factor 10A. So it inhibits the any of these DOACs. So then another study is ANNEXA 4 study. It evaluated andronicet factor 10A inhibitor treated patients with major bleeding within 18 hours. So usually whenever they administered andronicet alpha, this resulted in effective hemostasis in almost 80% of patients with ICH. So it's a good this one. And apixaban or rivaroxaban more than 7 hours if the patient is if the drug is already taken for more than 7 hours, bolus 400 mg, then infusion 480 mg for 120 minutes you have to give for over 2 hours. Suppose if the drug is taken less than 7 hours, you have to give double dose, that is bolus 800 mg and infusion 960 mg. So andronicet is still not available widely. The many times you can give coagulation factor supplementation, PCC or APCC can be used, and there is no sufficient evidence for FFP. Many a time FFP may not work in if you give in, especially DOACs, patients on DOACs, either dabigatran or apixaban or rivaroxaban, it may not help much. So if PCC is not available or not suitable, we can give activated charcoal 50 grams. Dialysis, as I said, it's good for dabigatran, but dialysis will not help for either apixaban or rivaroxaban, because most of the apixaban is protein bound. Almost 2/3 of edoxaban is protein bound. So it doesn't help much. Plasmapheresis may be tried in some of these patients. So suggestion of reversal agent, Factor 2A inhibitor, that is dabigatran, use idursulfimab, which is a first line drug. Factor 10A inhibitor, use antenexate alpha, which is a first line drug. Suppose if it is not available, either 4-factor PCC or activated PCC or even FFP. FFP is not indicated in either cases. So this is again the same comparison of major oral anticoagulation related studies. So when to restart? Now that, suppose a patient, you have started a patient on oral anticoagulation. Within 2 or 3 weeks, he comes back with a bleed. So many a time, they may not restart the anticoagulation. So that may cause more harm to the patient. Don't get scared just because the patient had bled on oral anticoagulation. Identify the risk factors. Suppose patient is having, CLD or CKD, choose appropriate anticoagulants, number 1. Second, most important is BP control. So it is not enough if only you measure one BP reading and you are happy with it. Many a time there may be surges of the BP, especially in the night or evening, or stress related, which may actually trigger the ICH. So you have to keep that in mind, control the blood pressure. So in most cases, there is a net clinical benefit in favor of restarting oral anticoagulation after a ICH. So usually after 2 to 4 weeks, we can restart safely the anticoagulation. Suppose if it's a large bleed requiring surgery and all, we can wait probably up to 1 month. But if there is a mild to moderate ICH, doesn't require any surgical intervention. Suppose you do a repeat CT after 2 weeks, which is showing a resolution of hematoma, probably you can safely restart the NOACs. So the optimum timing, usually they say 2 weeks, 2 to 4 weeks. So retrace study, that's a German study wherein they restarted anticoagulation after 2 weeks. The ischemic stroke risk was much lesser in them. So the American Heart Association usually advocates avoidance of oral anticoagulation for at least 4 weeks in ICH patients without mechanical heart valves and indication for oral anticoagulation. Suppose if there is a left atrial appendage is there, you do the left atrial appendage occlusion. So what are the future trends? Another target specific reversal agent in clinical trial is siraparantag. Actually, this is also now they are doing research on phase 3 trial in this drug. A small synthetic molecule that might reverse the activity of all NOACs, both factor 10A and 2A inhibitor. This is probably a promising molecule if we get a good result in this. So modified thrombin molecules as specific reversal agent for dabigatran has been investigated. So another thing what we commonly see is TPA induced bleed, TPA induced coagulopathy. So symptomatic ICH ranges from 2 to 7%, and majority of this patient develop within first 12 hours of TPA administration. So what do? Obtain a fibrinogen level, treat empirically with 10 units of cryoprecipitate. Suppose if cryoprecipitate is not available, or you can go up to fibrinogen goes more than 150. If it is not available or contraindicated, you can give antifibrinolytics. Tranexamic acid or epsilon aminocaproic acid can be used, especially if patient, we have seen some patient with gum bleed. The moment you give TPA, there is a significant gingival bleed. In them, sometimes we give tranexamic acid or epsilon aminocaproic acid. So this is one case wherein we gave TPA and patient bled. This is a coagulation, TPA induced bleed. So to conclude, NOACs appear to have a better safety profile compared to vitamin K antagonist. We can safely use them. Oral anticoagulation therapy, ICH is frequent and treatment is quite challenging. Restoring anticoagulation and lowering BP, these two are the most important therapeutic interventions what we can do to prevent hematoma expansion. It reduces mortality. Availability of coagulation tests for NOACs and point of care tests. These two are very important, especially when you are running a stroke program in emergency ward only. You need to have a point of care test machines. It will save time. Suppose you send to lab, they will take 45 minutes to 1 hour. You will waste time actually. So rather than that, you can have a point of care equipment in the emergency which will save time. Further investigations are needed to concerning reversal agents and resume NOACs in 2 to 4 weeks. So with this, there are some, for postgraduates, they can go through some of the interesting papers on how to, treat anticoagulation-induced ICH. So this is my neurosonology lab, and with this, I thank the organizers for giving me the talk, and it is open to questions.
Thank you so much, Doctor. Thank you for that lucid presentation. Now, as the next talk is almost a continuation of your talk, we'll have questions after the...
Sure.
Dr. Sudhir.
Yeah, so I think most of the talk was already covered, so it will be just like a refresher, and mainly for the postgraduate students. So, and I'll be talking about prothrombin complex concentrate and reversing anticoagulants. So patients who are taking anticoagulants, definitely they have a higher risk of bleeding, and that whenever we give anticoagulants, the main fear is that they can have a bleed, and that can worsen their outcomes, and sometimes the side effects of the drugs can be worse than the possible benefits. And almost about 20% of spontaneous intercerebral hemorrhages are due to oral anticoagulants therapy. So that's 1 in 5. And those who have bleeding, they can have increased mortality, and especially if the hemoglobin drops, definitely the risk will be higher. And if the bleeding is internal, like GI bleed or ICH, the mortality can be even higher. If it is superficial, we can compress and save the patients. So when do we think of reversing anticoagulation? So first is if the bleeding is severe, definitely, and many times patients require emergency procedures or surgeries. Again, we are forced to reverse the anticoagulation. And if there is minor bleeding with elevated INRs, then usually supportive treatment, and we can stop the medications for some time. Many times patients come to us with routine monitoring, INR is high, but nothing much, some little bit gum bleeding. We stop the anticoagulant for a few days and then recheck, and then it becomes normal, we can restart at a lower dose. So when we think of reversing, the first is warfarin, and usually vitamin K dose 1 to 10 mg, and then usually not repeated. Route, I think some patients will definitely require subcutaneous, some require oral. So it depends on the severity of bleeding, INR, and then onset of action is 4 to 12 hours if it is given IV, and with oral the action is much delayed. And full effect is, it starts in 24 to 48 hours. The second thing is fresh frozen plasma. Earlier we have used, it has been the standard of therapy for a long time, more than several decades. And the dose again, it is 5 ml per kg, usually 2 to 4 units, and maybe repeated if needed. And here also onset of action is quite fast, within 1 to 4 hours. It depends on the INR obviously. And duration of action is 6 hours or less. And so main advantage of AVP is rapid really acting, and no resistance is noted. Now we should also consider the risks of FFPs. When we think of FFPs, there are few risks, and they are mainly concerned with the volume, because it's not only the anticoagulant reversal, but also we have to give volume along with that. And because of that, the risks are mainly two. One is called TACO, and other is TRALI. So TACO is transfusion associated circulatory overload, and TRALI is transfusion related acute lung injury. So these are both linked to the volume that needs to be given along with FFPs, and that is the main limitation, because some of those patients can have renal problems, hepatic, cardiac problems, so a lot of volumes can't be given. Even healthy people, sometimes if the volumes are given, then it can lead to worsening of outcomes. And TACO is responsible for 32% of reported fatalities, and trally 26% of reported fatalities. So these are the, so sometimes again, so we are giving treatment to counter the side effect of one treatment, that is anticoagulant, and this treatment also will have some more side effects. So it's like it's a chain of side effects, and then because of that healthcare burden increases. They need to stay longer in the hospital, longer ICU stay, and then it pushes up the costs. And FFP administration is linked to TACO, and this is what study is also showing the same thing. So if you look at the pulmonary complications, 20% of people have pulmonary complications, those who receive FFP for warfarin reversal, and out of those 20%, TACO is the commonest circulatory overload in 12%, pulmonary edema in 7%, and trial in 1%. So this is not something uncommon. So 1 out of 5 patients who receive FFPs can have complications. And as I mentioned, it leads to extra burden on the healthcare system. About 29% patients have a longer length of stay. And so cost is definitely one of the main things we look at. In every hospital, patients want a little lesser bill. But this will increase the length of stay, longer length of stay, and also higher cost, 53% higher cost if we give FFP and patients have TACO. So these are the different things which was already discussed to reverse the coagulation pathway. And what are the plasma-derived products which can be used in bleeding? So these are the various options we have. FFP we already know and we have been using for a long time. Then 3-factor PCC, prothrombin complex concentrate, 4-factor PCC, activated 4-factor PCC, and recombinant factor 7A. Recombinant factor 7A, it was, I think, those who were practicing almost 15 years back, it was launched in the name of NO7, because one phase 3 trial was there which showed that it will limit the hematoma expansion in spontaneous ICH. But then subsequent trials came and showed that there is no clinical benefit. So after hype for 1 or 2 years, it just died down. So what are the main differences between these agents? So I think this table is the one which is the most important for all the residents sitting here. And if you look at recombinant factor 7A, as the name suggests, it works against only factor 7, vitamin K coagulation factors. See, when we say 3-factor, 4-factor, what we were talking about these things. When somebody says 4-factor PCC, 3-factor PCC, so the factors are 10, 9, 7, and 2. And fresh frozen plasma will work against 10, 7, and 2. So that will provide these 3. And if you look at 3-factor prothrombin complex concentrate, so again it has 10, 9, and 2. But the last 2, that is the 4-factor prothrombin complex concentrate, that as the name suggests, it has all the 4 factors, 10, 9, 7, and 2. So obviously if you look at this, the best option for us is 4-factor PCC. In terms of efficacy also, we also mentioned about circulatory overload, and we'll see that the volumes that we need to use for treating will be much lesser here. So the risk of TACO and TRALI definitely will come down if we use 4-factor PCC. And the 4-factor PCCs, each vial sterile freeze-dried powder, it has 250 international units, and it contains factor 2 175 to 412 IUs, factor 7 40 to 260 IUs, factor 9 250, and factor 10 150 to 500. So it has good amounts of various factors, and additionally also protein C, protein S, heparin, and total protein not more than 52 grams per liter. And it has to be reconstituted with just 10 ml of sterile water for injection. So that is the volume we are talking about, 10 ml. And where we have, for FFPs, much larger volumes are needed. And heparin, what is the role of heparin? So heparin keeps the factor 2, 7, 9, and 10 non-activated, and protein C and protein S just to mimic the natural milieu and confers lesser risk of thrombosis. So that's the point of keeping these things additionally in the 4-factor PCC. Now what are the approved indications? Because we have to look at evidence and follow the guidelines. So approved indications are treatment and perioperative prophylaxis of bleedings in acquired deficiency of the prothrombin complex correlation factors such as deficiency caused by treatment with vitamin K antagonist, or in the case of overdose of vitamin K antagonist when rapid correction of deficiency is required. So rapid correction is the key word here. And second thing is treatment and perioperative prophylaxis of bleedings in congenital deficiency of any of these factors when purified specific correlation factors are not available. So these are the two main indications. Then what are the potential indications? So many times we need to do emergency reversal of NOACs and also bloodless surgery. So these are potential indications, not in the guidelines, but it could be clinically relevant for us to use in some situations. And the dosage, Dr. Suryanarayan also mentioned, so the pre-treatment INR should be measured as close as possible to the time of dosing. So because this INR keeps fluctuating, so it will keep changing. So when we are ready to give this 4-factor PCC, so around that time we should check the INR. And then as was told, so INR is the one which decides how much dose we have to use. If the INR is say between 2 to 3.9, it is 1 ml per kg body weight, 4 to 6 is 1.4, and more than 6 INR, it is 2 ml per kg body weight. So as the INR is higher, the dosing also will be higher. And then at the bottom we see the approximate dose of international units, factor 9. So factor 9 is like 25 for up to 3.9 INR, 35 for 4 to 6, and 50 for more than 6. And the correction of the vitamin K antagonist induced impairment of hemostasis is reached within about 30 minutes after IV injection. So half an hour is the time taken, so it's quite rapid. And so it should be considered for patients who require urgent reversal of vitamin K antagonists, because vitamin K takes much longer, of 4 to 6 hours. So one thing is the time also. So if we require, and then also repeated dosing with prothromb requiring urgent reversal of vitamin K is not supported by clinical data. So not recommended. So it says for single dose. Now already I briefly mentioned, so what are the, just to summarize, what are the advantages of using 4-factor PCC over fresh frozen plasma? So some things are obvious, because we don't need to check the blood groups or cross matching, which also takes little bit time. No waiting for blood to thaw, less risk of viral transmission, very relevant, because we have heard of many cases of infections including HIV with transfusion of blood products. No risk of TRALI, so transfusion-related acute lung injury is very less, or there is zero risk because the volumes are less. Less complications from volume overload. So here totally we are talking about less than 200 ml of infusion versus 800 to 1000 ml if we use FFPs, and reduced transfusion reactions and much quicker reversal. So time 30 minutes versus a few hours. And this is supported by various trials in the last few years. So what I mentioned, so basically the time taken is very fast, and all the trials you can see as 4-factor PCC is in the red line. So within about 2 to 4 hours, the INR correction is noted, versus if you're using plasma, then it's taking almost 20 to 24 hours for correction. And safety also has been established in trials. And another indication is patients requiring urgent surgeries or invasive interventions. So for that also data is there. It is efficacious as well as safe also. Again, this one shows the fraction of patients without INR correction. So it is much higher for the plasma, which is in the green line, and then the red line shows 4-factor PCC. It's much lower. So most patients, almost more than 90%, they achieve correction of INR. And safety again was established in the trials. This one gives the summary of various phase 3 trials. And then is there an efficacy of PCC for the reversal of rivaroxaban and apixaban? So there are studies on that. UPRATE study, 84 patients They received median dose of 2000 IUs, and as we can see, definitely effectiveness was noted in most patients. Some slides I'm just skipping. So it's a safe alternative for managing direct F10 inhibitor related major bleeding also, because it was not, Dr. Surya mentioned that not freely available. In our country we don't have that. So this could be one alternative to be used. All cause mortality is very less, 0.16. Thromboembolism rate also very less. So what are the guidelines supporting the use of 4-factor PCC? So Neurocritical Care Society and Society of Critical Care Medicine 2016. What it says, benefits of PCC include its fast preparation and reconstitution time, rapid INR reversal, small volume, and lower risk of infection as compared to plasma. So these points are well supported by the clinical trials. And prothrombin complex concentrate use in VK vitamin K antagonist in ICH leads to faster INR reversal, less hematoma expansion, and similar or better mortality rates and functional outcomes compared to plasma. Then the next year, American College of Cardiology, for patients with vitamin K antagonist associated major bleeding, administration of vitamin K must be accompanied by a repletion strategy. PCCs or plasma, only 4-factor PCC is not available. So 4-factor PCC is the first one. If it is not there, then we can use other products, and then use a smaller volume at a much faster infusion rate compared to plasma, and it is preferred. So that's the same thing was reiterated there also. And similar things were told by American College of Chest Physicians and GI endoscopy. For warfarin reversal, the 4-factor PCC is the appropriate reversal agent. So these are all guidelines are in the last 10 years. Other societies also same thing. AHA, this one gives just the table of what we are already doing. So vitamin K antagonists, INR 1.3 to 1.9, 4-factor PCC, and then more than 2 4-factor PCC, and then also followed vitamin K. Dabigatran, we have a specific reversal agent, and if it is not there, then we can use 4-factor PCC. Same thing for other agents also. If we have a specific antidote available, we can use that. If not, then 4-factor PCC is the option. For heparin, again, protamine is the... So 4-factor PCC is superior to plasma for warfarin-induced ICH to rapidly replace vitamin K-dependent coagulation factors. And it is also, it leads to reduction in hematoma expansion, 18.3% versus 27%. So, and there is no difference in the side effect profile or thromboembolic events. This is just, I think already we discussed this. Cost and value we already have discussed, and I think same thing. So it's a cost-effective treatment than fresh frozen plasma. To conclude, it is a superior alternative to fresh frozen plasma for urgent warfarin reversal. It provides superior hemostasis, faster INR reduction, and then faster administration with lesser volume, and it is cost-effective also. Thank you.
Thank you, Dr. Sudhir, for that lucid presentation. So, as physicians, we are worried about anticoagulants, and surgeons, as you mentioned about antiplatelets. Any questions? We can take them. Yeah.
We can have more questions.
Any questions, please? Dr. Kaur.
Yeah, I want, both talks were very good, fantastic. I want you or any neurosurgeon to comment that following brain hemorrhage, you said that if it's a small brain hemorrhage, we can restart oral anticoagulants after 2 weeks. And if it's big, then after 4 weeks. That's for a brain hemorrhage. What about subdural hematoma? Because the difference between subdural hematoma and brain hemorrhage, subdural hematomas are sometimes known to rebleed within that cavity, and that ooze, what they call chronic ooze. So how do you tackle subdural hematomas?
Subdural hematoma guideline says that at least 4 weeks we have to wait. So by 4 weeks, if there is no bleeder, so then probably we can restart, provided the indication for anticoagulation is strong enough. Suppose if it's a paroxysmal AF or it's just a one run of AF, we can actually, sometimes we can avoid giving anticoagulation. But if it's a persistent AF or if there is a thrombus sitting in the LA or LV, then we have to definitely consider giving.
Sudhir, this, thank you, sir, thank you. This 4-PCC basically is kind of a broad spectrum, essentially for vitamin K, but you can give another. But what about things like hemophilia, which is a factor 8 deficiency? I was particularly looking at factors, it does not correct factor 8, that's not in there. So in hemophilia, it will not work probably.
It will not work, yes. I think, may I invite Dr. Yukesh Mishra sir to give the mementos to our speakers. Please, sir. First is Dr. Subhash Kaul, sir, please.
ये फोटो में मिलना चाहिए.
मिलेगा, मिलेगा सर. Next, Dr. Surya Narayan Sharma, sir. Then I also will get one moment.
We all should appreciate Sudhir for all his efforts, actually. Give him a big hand.
Thank you. I think now we'll come to the last session. It is so always, you know, what we say is that neurosurgery is definitely very important and useful for us. So even, it's not that last means the least important, last is always the best. All that ends well is the best. So we have two eminent speakers for this. And before that, I would like to invite our chairpersons, Dr. B.G. Ratnam and Dr. S. Rajesh Reddy, who are going to chair this session. Both are eminent neurosurgeons in Apollo Hospital, Hyderabad. Please come, and then they will invite the speakers.
We welcome Dr. Rahul Lath from Hyderabad, Apollo. He's going to talk on decompressive surgery for ischemic stroke.
Which is the first one? Yeah. Which is a laser pointer. Yeah, let's cover. Which is a laser. Good afternoon. So, I will be speaking on the role of decompressive surgery in ischemic strokes. So, now in strokes, the surgery is done for two kinds of strokes. One is the anterior circulation and one is the posterior circulation. So, in supratentorial strokes, occlusion of the middle cerebral artery or the ICA with a very large area of infarct. It happens in up to 10% of the supratentorial strokes, and in which early or in the stroke, more than half of the MCA territory is involved, with the deeper structures, basal ganglia, and maybe additional vascular territories like the ACA. And there is a early shift, midline shift of more than 4 millimeters, which is measured at the level of the pineal gland. It occurs in the first, actually, few hours. And the highest frequency of death and deterioration starts on day 3, and up to 80% mortality in the untreated groups. And this is also referred to as the malignant MCA infarct and malignant brain edema. So the clinical presentation of this stroke is earlier on in the disease, the patient has a very dense deficit, visual field deficit. They may have gaze deviation, aphasia or neglect, an impaired level of consciousness earlier on in the, within a few hours of the onset of the disease. They may have raised pressure symptoms, pupillary changes, and also develop papilledema at a later stage. And the severity of the neurological deficits must be known to all the neurologists, the NIHS score. The lower the score, the better is the prognosis, and higher the score means more deficits. And patients with MCA infarcts usually have scores of more than 15 for non-dominant strokes and more than 20 for dominant hemisphere involvement. And when they measure the outcomes, this is measured by the Rankin score, modified Rankin score. This is the NIHS score, very detailed workup here, between 0 to 42. And this is the outcome studies where you see the outcome of score of 3 or more means the patient is independent. This has got a fairly good outcome. 4, 5 is disabled patient, and 6 is death. So what are the predictors of a malignant infarct, and which are the patients we need to watch out for and offer early surgery? A high NIHS score, okay, that's a predictor of a malignant, earlier on in the onset of the stroke, history of hypertension, blood pressure rise in the first 12 hours, a female patient, congestive heart failure, a young patient, which does not have, elderly patients have atrophy, they can accommodate the raised ICP, but not a young person. And what are the radiological predictors of a malignant infarct? On the CT scan, early ischemic changes in more than 50% of the MCA territory, the aspect score of more than 7, which I will just show a little bit more later, infarct volume of more than 220 ml, and a midline shift of 4 millimeters within 24 to 48 hours of the onset of the stroke. The dense MCA sign, again optic nerve sheath diameter and the transverse diameter of the eyeball and the ratio, suggesting the raised pressure. And on a CT angiogram, the clot burden and proximity of the clot in the vessel and poor collaterals, and occlusion of carotid on the CT angiogram. And if there's a CT perfusion study which involves more than 2/3 of the MCA territory, that also will predict an MCA infarct. On an MRI, if your infarct volume is more than 80 cc's in the first 6 hours on the diffusion weighted images, the high risk of herniation if the infarct volume is more than 145 cc by 14 hours. And ADC compared to the opposite side, which is less than 80% of the contralateral. I just show some of the examples. Other predictors are on Doppler studies, and the biomarkers are, most important ones are the high glucose and high WBC counts. Based on this, a lot of scorings have been developed. We just give you the lower the score, less chances of you having a MCA infarct. Higher the score, you have a high chance of getting a stroke. Again, what they have studied here are the aspects show the NIHS, the severity of the disease, presence or absence of collaterals, heart failure, blood pressure, high WBC count, poor sugar control. All these point towards a high risk of patient. And most important, again, the factor is on an early diffusion image, if more than half your territory of MCA is involved on the diffusion weighted images, there's a high chance that you will go on to develop a malignant MCA infarct. This is just showing the aspect scores based on just early CT scans. They have divided into 10 regions, and a score of more than 7 on involvement of the CT scan will predict a malignant infarct earlier on in the disease. Similarly, this is just to show you what a diffusion image will look like. These are pictures I have taken out from the decimal trial, where the patients were randomized based on the CT and MRI into a surgical group. This patient went on to a surgical intervention. If you see, this is the early MRI. And based on this, they randomized and did an early surgery. This patient had a good outcome. And you can see that on an early MRI, more than half the territory of MCA is involved on diffusion. And this is a follow-up scan, which is 6 months later after cranioplasty. Patient did well. Now, next scan, again from the decimal trial. This shows the early CT, early MRI, diffusion, more than half the territory involved. This patient was not operated, was put in the medical arm. And on day 3, this is the CT scan on day 3, the patient had a large infarct, herniated and died on day 3. This is right from the trial, images from that. This is also just to show you, this is a very small diffusion weighted image, small infarct. And this is the perfusion study, a lot of mismatch, patient had thrombolysis, and this is the outcome, good outcome. This is an early MRI again, within 2 hours. It shows a very, more than half the territory is involved. The perfusion also not much of a difference, and this patient went on to develop a large infarct. So early onset, early diffusion weighted MRI is a very good predictor of a middle cerebral infarct, and these patients should be operated early. So what happens in a malignant infarct? So the perfusion drops to less than 20% of the baseline. It leads to cell wall disruption. Again, the initial aspect is a cytotoxic edema, which is the one which you see in the first few hours in diffusion restriction. Water builds up inside the cell. And then you go on to develop a breakage in the blood-brain barrier, which after 6 hours leads to the vasogenic edema. And slowly there is swelling, and there will be a midline shift. This one again. There will be a midline shift, raised ICP, and ultimately there will be transtentorial herniation and brainstem compression and death. So that is the pathophysiology. Similarly, in the malignant cerebellar stroke, what happens is about 20% of the posterior circulation strokes tend to progress and develop edema, brainstem compression, either tonsillar herniation or upper herniation, and or they may have hydrocephalus. And in severe cases, bilateral cerebral infarction and brainstem infarction occurs. Again, the arterial pattern is very variable. It can be one artery or multiple arteries involved. And there is no randomized trials which compare the surgery versus best medical management for a posterior fossa stroke. Again, the aspects has been done for the posterior fossa strokes also. They have a similar pattern, but not used commonly. Now coming to the timing of surgery, all the trials done so far have shown that if decompressive surgery is done within 48 hours of the stroke onset, there is survival benefit and better functional outcomes also. And few studies have shown that surgery within 24 hours compared to more than 24 hours has outcomes which are better than the 24 hours later done surgery. And now, most of the studies which have enrolled patients for up to 96 hours, they have shown that if you do surgery after 72 hours, there is no benefit. In fact, it may be even harmful and the outcomes are poorer. The newer studies which are coming out, they have shown that surgery done within 6 hours actually has the best outcome. So if you can pick up a patient whom you think will develop a malignant infarct, and you can operate within 6 hours, apparently the results are the best. And all the studies have shown that once you have clinical and radiological features of herniation developing, this outcome is poorer. So the key, therefore, is to identify the patients at high risk and operate before the onset of herniation. That's what the aim should be. So surgical technique is a pretty standard surgery where what the recommendation is that the incision should be at least 12 centimeter and your size of the craniotomy should be at least 15 centimeters, and you have to have subtemporal decompression. You have to remove the basal bone also, and then you have to open the dura, and thereafter you can either do a duroplasty or leave the dura open. Again, that depends on what you practice, and the size has to cover the entire infarct, but usually a 15 centimeter size should cover most of the infarcts in the supratentorial region. And this is just where they have monitored ICP. They have shown that with the decompressive craniotomy alone, your ICP can fall from 30 down to 10. And the opening of dura in this fashion, in a wide-based, in a radial manner, further brings down the ICP. So your main purpose in this malignant brain edema is to bring down the ICP. In the posterior fossa surgery, again, the principles are similar. You have to have a wide posterior fossa decompression. And thereafter, the other surgeries which have been proposed are to either remove the infarcted brain and to open the dura, remove the infarcted brain, and to put an external ventricular drain. That is what if there is a hydrocephalus. That's what is usually done. Post-op management, you have to maintain the PCO2, PO2 levels, continuously monitoring of the blood pressure, maintain it at normal levels, normal glycemic control, and the elevated ICP, usually this is for non-operated patients, medical management of the elevated ICP. We'll skip that. So now I'll come to the talk some about the complications of decompressive craniectomy. They can be either early complications or late. Infections, hemorrhage up to 10%, either subgaleal, extradural, subdural, because a lot of these patients are already on either antiplatelets or anticoagulants. So there's a high chance we see. And seizures, about 6 to 12% risk of seizures in the first 5 years. Then non-infective wound dehiscence, subdural and interhemispheric hygromas and hydrocephalus. Then in the late stages, you can have syndrome of the trifine sinking flap syndrome with late paradoxical herniation. And then general complications related to ICU stay, UTI, pneumonia, DVT, and sepsis. So this is patient which shows subdural collections in the extraaxial space after a decompression. And this is the late complication. Again, the minor subdural collections can be treated with a simple cranioplasty, and you may not require a VP shunt, but sometimes patients with hemicraniectomy develop large ventricles which do require a shunt. What about hemorrhage after decompressive surgery? More often with patients who are on antiplatelets. Up to 10% have radiological evidence of hemorrhage after decompression surgery, and a few of them do require repeat surgeries. And a large number of hemorrhagic transformation occurs even prior to decompression in many of the strokes. It is less in post-thrombolysis and thrombectomy patients when compared to patients who are on antiplatelet drugs. And cranioplasty by itself is an independent risk factor for post-op hemorrhage. This is just to show you one of our cases which had a hydrocephalus, and after the cranioplasty and shunt developed a very large extraaxial collection which had to be reoperated. So this is an independent risk factor. And that is why we like to, if the shunt is required in a decompression patient, we like to stage the cranioplasty and shunt at a different setting rather than doing them at the same time. And we usually keep the bone in the bone bank or in the anterior abdominal wall, but in cranioplasty we use the autologous bone or the sometimes autologous ribs, titanium mesh, and customized, nowadays we are using customized titanium implants or acrylic. And it's ideal to be done when the brain swelling settles down, usually within 3 months of the, when we are using the autologous bone. And if it's more than 3 months, we use a titanium mesh. So now coming to the benefits of surgery versus best medical management. This is just one of the review articles published in 2021, which has compared a lot of the clinical trials which compare the best medical management and surgery for a large MCA infarct. So here they studied how surgical decompression compares with best medical management. And they reviewed about 488 individuals from 7 randomized trials. So these are all the fancy trials which have been done till now. And this is the pooled data from all of them. And you see the medical treatment arm, the surgical treatment arm, this is the total number, almost matched in everything, all age groups. And what is very interesting here is they looked at the outcomes at 1 year, they looked at death, and if you see, this is the MRS of more less than 3, which is your patient is independent, and then they found significant difference in both the groups. This is 37% who had a better outcome compared to 15% good outcomes in the medical population. When they looked at death, 29% in the surgery population versus 71%. So there's a lot of difference, and which shows that it is definitely a life-saving procedure for a large hemispheric infarct. And now this is just the summary of all that data. This is the best medical management, and this is surgery. For everything, the surgery has a better outcome. The only thing which they say is timing. If your timing is beyond 48 hours, your outcome is not good. And that's the only thing we should, if you have to do the surgery, you have to do it under 48 hours to have a better outcome. So now what happens? Most of these trials, they end at 1 year. They have reported outcomes at 1 year. What happens after that? So there's limited data on long-term outcomes, quality of life, and the patient-reported outcomes. You have saved the life, but how is the patient after that? So actually some studies are done which have shown that 60 to 80% of the patients and caregivers, when they were asked retrospectively, they agreed that they will again have the surgery, or they were happy that the surgery was done. And quality of life study showed that it was impaired in almost half the patients. Major depression was seen in up to 60% of the patients who had undergone decompressive craniotomy. And no patient had returned to any prior employment. But most patients also said that the quality of life was acceptable to most of them, and they do not regret having the decompression done, which is very important. And again, there was no difference between the dominant and non-dominant groups. However, the aphasia group is underrepresented in all these reports, because obviously they were not able to communicate. So what is the role of surgery in posterior circulation ischemic strokes? There are no randomized trials. There's only one prospective observational studies. And again, that is very flawed, because in the surgical group, a large percentage of the patients were already comatose, and no patient in the medical group was comatose or had altered sensorium. So these are already very flawed studies. They're all retrospective or multiple case series. So the various surgeries have been described, which I've already mentioned. And but what they mention is without treatment, the mortality is up to 80% in a posterior circulation malignant stroke. Again, this is the same thing what they say. So are there any guidelines? The AHA says that if there's a patient with a stroke, you have to transfer it to a higher center where there is neurosurgical facility. Patients who are at risk of developing a MCA infarct. They say less than 60 years who are clinically deteriorate should have early surgery. Greater than 60 years, similar approach may be considered, but those people have a higher disability. And for cerebellar strokes, they mention that you should have suboccipital decompression with or without duroplasty and a EVT. This is the recommendation. One more recommendation guideline is saying that you should at least have the incision of 12 centimeters and the length, the size of the craniectomy should be at least 15 centimeters. These are the things mentioned in various guidelines. So what about decompression in children? It's very rare in children, but again, there are no randomized trials, few case reports. Whatever, and then the study suggests the surgery is delayed, but patients still have a better outcome compared to adults. Surgical techniques are the same. Blood loss is a concern in smaller children during surgery. This is some of our cases here which we have done. Just to show you, this is one case. I think Dr. Rajesh is an endovascular person. He has done thrombectomy in this patient. Still the patient went on to develop a large MCA infarct. And what the literature says is, I think now with the trend of thrombolysis and with thrombectomies and bridge therapies, the incidence of these large infarcts is coming down. Or at least it should come down. I think our neurologists will be able to tell that better. But if these patients go on to develop a MCA malignant infarct, it has a much worse outcome when compared to the non-thrombolized or the non-thrombectomized group. So this is very useful if you have to counsel these patients. So in summary, it's very important to identify patients who are at risk of getting a MCA infarct. And it is a life-saving procedure, and it should be done ideally within the first 48 hours. And if you can identify the patients and do it earlier, it's even better. That's, I think, the very important message. If it's earlier done, better the outcomes. In posterior circulation strokes, the threshold for decompression should be lower, as delayed surgery has a very poor outcome. These are the papers for people to read. Thanks.
We'll have the discussion at the end of the next session as well. Dr. Prafulla Kumar Sahu from Bhubaneswar. Now he is going to talk on surgical management of intracerebral hemorrhage.
Good afternoon to everybody, chairpersons, and all the neuroscientists sitting in front. I thank, at the outset, I thank Dr. Sudhir for organizing this. It's an excellent neuro conclave, and also inviting us to give a lecture on, in a neurology forum, to give a lecture on surgery for hemorrhagic stroke. I thank him for that, and all his team. It's very well organized and should be conducted. As a matter of fact, all India Apollo group, they should have the neurosciences update at least once in a year, and people should be given the opportunity, and postgraduates must attend this to see what quality work is being done. As a matter of fact, एक और पेन ड्राइव है तो इसमें लोड कर दो, और एक पेन ड्राइव लोड कर दो। Sorry, this has been changed yesterday only, therefore there is little, they cannot connect this. It will take one. So what I would like to say, that definitely in hemorrhagic stroke, we have all discussed regarding how hemorrhage occurs. It could be, as we know, this could be hemorrhagic stroke, can be subarachnoid hemorrhages and intracellular hemorrhages, but we are not discussing regarding subarachnoid hemorrhages here, and intracellular hemorrhages. And the causes why there are intracellular hemorrhages, we have all discussed. There is a long discussion how antiplatelets when you are using, anticoagulants you are using, we get all these things. And when you use anticoagulants and antiplatelets, also as Dr. Kaul, who is a master of stroke, and he always presents regarding primary prevention, secondary prevention of stroke, subdural hematomas do occur if you give antiplatelets, and with trivial trauma, there can be subdural hemorrhages, and that will discuss what to be done such subdural hemorrhages. Yes. इसको फुल सही था मुझे So greetings from Apollo Hospital, Bhubaneswar. There is still some problem probably in connecting the computer. ठीक से लगाना था दे दे this side and go back.
This one.
This is for back, this is for forward.
This is forward, this is back. Okay. This one is forward.
Okay.
That one is.
नहीं previous one इसको close कर दो. Why do you open this? Close this. This is automatic. अच्छा. एक उल्टा बता उल्टा नीचे वाला सही बता ठीक है तो इसको इसको सीधा करो मुँह में लगाना ठीक से. So brain stroke is the third leading cause of death in developed countries and fifth in India. Incidence of ischemic stroke is 85% and ICH is 15%. In the first 30 days, approximately 50% of deaths are directly due to stroke, whereas other 50% are due to complications caused by morbidity like sepsis, pneumonia, renal failure, and venous sinus thrombosis. 1 year after the stroke, hemorrhagic stroke, 60% will die, 20% will be unable to perform their activities of daily living, and only 20% will be functionally independent in ICH. It is basically two types. It's a ischemic stroke, we are not, already it has been discussed, and the hemorrhagic stroke we will discuss regarding intracerebral hemorrhages. And as you look at the next slide, you will find that almost 3 lakhs intracerebral hemorrhage cases occurs in इसमें नहीं तो ये करना you stay here then stay here. So you will find from this slide almost 3 lakh cases of hemorrhagic stroke occurs in India every year, and the highest mortality has with hemorrhagic stroke, and there are 38% survival within first and next. Now death rates, you see the death rates, intracerebral hemorrhages, on 30 days there are 50% deaths, 1 year there is 60% deaths, at the end of 5 years the death rate is almost 70%. Next please. So this is the sites, as you all know. The basal ganglia has got the highest mortality up to 50%. Cerebral hemisphere, it is 30%. Brainstem and cerebellum, 15 to 20%. Intraventricular occurs almost 40% cases. If there is intraventricular hemorrhage associated with lobar or brainstem hemorrhage, there causes acute hydrocephalus, high intracranial pressure, and the results are poor. Next please. The classical presentation in ICSR, if there is a sudden onset of focal neurological deficit, altered consciousness, and elevated blood pressure. If there is supratentorial hemorrhage, this will give rise to contralateral sensory or motor deficit, aphasia, gaze deviation, and hemianopia. If there is infratentorial hemorrhage, the signs of brainstem dysfunction will be there, lower cranial nerve palsy, ataxia, nystagmus, and dysmetria. Elevation of blood pressure occurs in 90% of cases and seizure in 10% of the cases. Next. Intraventricular extension of lead into the ventricle may cause hydrocephalus. Rarely blood finds way to subarachnoid space, the hemorrhage is much less. A large hemorrhage can raise ICP to the level of the blood pressure until bleeding is tamponade. Depending on the clot location, this can result in brain herniation, compression of the brainstem, and it may ultimately, if this is severe, it may lead to death. Cerebellar clots greater than 3 cm diameter has a poor prognosis if not treated early. Next please. Nearly 25% initial alert patient presenting with ICH, secondary deterioration level of cancer occurs within first 24 hours due to hematoma expansion and edema formation. Early repeat CT scanning appears to increase the rate of detection of hematoma enlargement. Hematoma enlargement after 24 hours is repeated to be rare, though it has been said up to 4 or 5 days it could be that there could be increase in the size of hematoma. Factors associated with enlargement includes heavy alcohol consumption, liver disease, systemic blood pressure, which is greater than 200 millimeter of mercury. The hematoma volume is a great predictor of mortality and morbidity. One of the strongest predictors of mortality and morbidity is ICH in the hematoma volume. Substantial early hemorrhage growth in patients with ICH is common and is associated with neurological deterioration. Next, please. You have also from this CT scan that in the early stage when the hematoma is low, but after 6 hours, if your patient is deteriorating clinically, you take a CT scan and find there is a massive bleed with midline shift and herniations. Next, please. So spontaneous intracellular hematoma expansion is associated with worse ICH outcome. There is now a range of neuroimaging markers that along with clinical markers such as times in stroke onset, use antithrombotic agents help to predict the risk of hematoma expansion. These neuroimaging markers include signs detectable by non-contrast computed tomography, non-contrast CT scan. The diagnosis of intracellular hemorrhage, no specific or no advanced form of invasion required. If you do a CT scan and CT angiogram, it will confirm the bleed, it will estimate the size, and it will identify the underlying lesion. Next, please. MRI is very rarely required in the case of intracellular hemorrhage unless you want to detect some other pathologies, suppose bleeding from some injuries. For the diagnosis of intracellular hemorrhage or treatment, MRI may be rarely required. MRI only detects if there is vasogenic edema or cytotoxic edema. Next, please. So these are the MRI pictures which can be done, which will only show the vasogenic and the cytotoxic edema. Next, please. It is important to remember that the management of spontaneous ICH is an emergency medical situation. And just like an acute ischemic stroke, time is equal to brain in these days as per recent guidelines. So you have to tackle as per the spontaneous intracellular hemorrhage, the American Heart Association, American Stroke Association guidelines for management of spontaneous primary ICH only. It does not include subarachnoid hemorrhage, other things. It does not include ICH due to trauma, structural lesions such as arteriovenous malformations, saccular aneurysms, or hemorrhage-prone neoplasms, and focuses on pathologies such as arteriosclerosis and cerebral amyloid angiopathy. So, an American Heart Association, American Stroke Association created guidelines, recommendation for the management of spontaneous ICH. Next, please. So, the commander of the ship said, if it becomes at all doubtful, let me know, I'll just be inside. But just in a hemorrhagic stroke which is increasing, if you do not tackle them properly medically and subsequently if required surgically, then it will sink. Next, please. Next, please. However ill a man may be, he is entitled in our law to every hour that God granted him. There is a belief when you had been students, and that time to say, if there is hemorrhagic stroke, you should do masterly inactivity, no treatment is required. You give Ryle's tube feeding, you give anticonvulsants also are not being given, that was the thing, but this has changed. You have to tackle this situation as every case occurs. However ill a man be, he is entitled in our law to every hour that God grant him. That hours may be most precious and most important hours of a man's life. There may be business to transact, gift to be given, other unfinished job has to be done. Therefore, it has not to be taken lightly from the beginning if a hemorrhagic stroke comes. Next, please. For an emergency perspective, the guidelines emphasize system care, nothing that stroke network improves outcome due to timely recognition, transportation, and pre-hospital notification. The recommendations for spontaneous intracellular hemorrhage in the pre-hospital setting are identical to ischemic strokes. This is because despite efforts to distinguish between the two entities clinically, it's just not possible unless you do a CT scan. Next, please. Why ICH kills? It kills because of mass effect, RBC changes, brain edema, transternal herniation, transfalcine herniation, and tonsillar herniation. Next, please. These are the guidelines of prognostication in ICH score. It covers the Glasgow Coma Scale, ICH volume, age, IVH, whether there is intraventricular hemorrhage or not, and infratemporal hemorrhage or cerebral hemorrhage is there or not. If this score is 5, it is said that 100% patient will die. We should not go with this prediction. Next, please. Overall early prognostication ICH is difficult and uncertain. Therefore, the guidelines strongly recommends using I-scores for a measure of severity only, and not for mortality, and not limiting treatment based on severity alone. At the time, there is a lot of uncertainty about the true mortality in large bleeds. Practically, if your patient is dependent and pre-palliative before ICs, they are likely palliative now, but otherwise, prognostication is difficult to ascertain in hyperacute settings. Therefore, in the emergency medicine context, unless there is a pre-specified wishes, treat first to allow time to prognostication and approach goals of care later. So therefore, one should neglect from the time you see a hemorrhagic stroke, it must be properly handled. The goals of treatment will be supportive and specific. Supportive treatment should start from the diagnosis itself or before diagnosis itself. Next, please. So it has to be transferred to a center having stroke care and neurosurgical facilities. It should not be sent to a place where neurosurgical facilities are not there. Provide basic advanced life support system during transfer of the patient, admit to ICU. Very important, the new guidelines is control of hypertension will come to the after a while, and if somebody is on anticoagulant, must be withdrawn. Next, please. Now, the emergency management is blood pressure control, control of diabetes mellitus, fever control, seizure prophylaxis, osmotherapy. I will not go to the detail because all of you know, and ventilator support. Next, please. The American Stroke Association recommends early initiation, continuous, smooth, and sustained blood pressure control. What is the drug to be used about, how it has to be given, but sustained and continuous monitoring, and should not be less than 130 millimeter systolic blood pressure. Next, please. The overall recommendation is to use what you are comfortable with and what medication available to you for control of blood pressure. And also they do not make any recommendation on invasive versus non-invasive BP monitoring. You need not run for an arterial line for monitoring the blood pressure in such cases. However, it is reasonable to consider an arterial line if you have a patient with difficult to control blood pressure or those you are starting an infusion. Next, please. The worst outcomes as with the ICs are, if there is large hematoma, evidence of intraventricular extension and initial decreased ECS. Therefore, the treatments aimed at limiting this expansion are due to direct pressure effects should be the focus in the emergency setting. These include BP control, a reversal of anticoagulation, and neurosurgical intervention where required. Next, please. Now, different methods which are followed are management of raised ICP. So for management of raised ICP, normally you have to put IC monitor, and this can also help when you are putting the IC monitor, you can put a external ventricular drainage along with that. That will help in monitoring the ICP, and also for drainage of, if you have to do only a external ventricular drainage where there is only small gangliothalamic bleed with intraventricular extension with there is large hydrocephalus or hemorrhagic hydrocephalus. Next, please. So there are two critical level 1 recommendation for spontaneous interstitial hemorrhages as per recent guidelines. Consider an external ventricular drain in patients with ICs with intraventricular hemorrhage and decreasing loss of level of consciousness. Posterior fossa decompression is recommended for patients with cerebellar hemorrhage with evidence of brainstem compression. Next, please. Hydrocephalus, large size or deteriorating otherwise also need to be attended quickly. Surgically accessible bleeds may have improved outcome with surgery versus medical therapy alone in selected patients. The evidence shows that in younger patients and those with lobar bleeds close to the cortex without intraventricular extension shows improved outcome with surgery versus medical therapy alone. There are many things have to be changed with every, as a matter of fact, American Stroke Association, Heart Association, they are almost every year guidelines, which are not there, as I said, during our student days, master inactivity with the treatment for hemorrhagic stroke, every year changing guideline depending on the experience they are finding and the requirements. Craniectomy versus minimal invasive evacuation is based on the center and surgical experience. minimally invasive approach is newer with promising evidence. And as more evidence established, the recommendations are likely to change. Next, please. So therefore, if in a spontaneous intracerebral hemorrhage, neurosurgical intervention may be more beneficial in certain cases like large ICH in young patients. They recommend up to less than 65 years, but I do not agree with practical experience. If there is a hematoma which is small, intraventral, small surgical procedures should be done in such cases. It should not play if somebody is more than 65. As a matter of fact, you find with the elderly population, now there are more people those having stroke. Ultimately, they die of heart attack or brain stroke. Therefore, if the hemorrhagic stroke is there, which is 10%, and you have to deal such cases, even if somebody is more than 65%. 65 says, superficial ICH less than 1 centimeter from the cortical, large of surface has to be tackled surgically. ICH associated vascular neoplastic lesions also has to be tackled. Cerebellar ICH, as I said, if it is more than 30 cc, then it has to be operated, otherwise the morbidity will be much more. ICH intraventral extension must be tackled. But what is the level of surgery what to be done from minimal access with newer equipment, newer infrastructure? Minimal access surgery can be done in certain cases to improve, save life. Next, please. IC monitoring, as I said, has to be done in subarachnoid hemorrhage with hydrocephalus. If even elderly person, 75, 80, if there is intraventricular hemorrhage with hydrocephalus, you can do IC monitoring with drainage. And with that also, many people have. If you leave it, they will die definitely. Even with score of 8, 9, you have to do this and they survive. Next, please. So this is some of the examples where even large hematoma with, so IC monitoring has been done and such people could be saved. Next, please. So surgery equipments required are, as I said, equipment is required for minimal surgeries. IC monitor must be available. Bipolar neuroendoscope is a system which will help in intracranial minimal access evacuation of hematoma. High-speed drill, of course, required. And it could be endoscopic, it could be stereotactic system, neuronavigation, neurosurgical microscope, and intraoperative O-arm. These are all helpful to have minimal access surgery and to have morbidity, less morbidity so far as surgery is concerned. Next, please. So what we have done during my 30 years, IC monitoring, we have done 120. We had one boy who had a project to do IC monitoring in ischemic and hemorrhagic stroke. 125 cases we have done IC monitoring. With that also, EVD has been done, external ventricular drawn has been done even up to above 65 or 475 cases. And endoscopy, third ventriculostomy. When you find there is a cerebellar hematoma which is small or is a brainstem hematoma, and it is causing obstruction to the CSA pathway, causing hydrocephalus, endoscopic third ventriculostomy has been done, and such some cases they have improved and they have leading now normal life. So endoscopic third ventriculostomy, essential item, minimal access thing which can be done in these things. So the evacuation can be endoscopic evacuation. Earlier used to rigid endoscope evacuation. These days you do with normal endoscopy, you can do evacuation, stereotype guided evacuation, image guided evacuation, and craniotomy. It could be mini craniotomy with evacuation of hematoma if it is surface hematoma, or microsurgical evacuation, or as been described for decompressive craniotomy, it could be like is malignant MC. In fact, you can do a decompressive craniotomy. These are the procedures which can be done in different cases depending on the case. Next, please. So this is CSF drainage with EVD. Next, please. So this you can drain and you can monitor the ICP, as I have told you. So both the things can be done at the same time. One of our boys, DNB student, had project, so he had done 100 IC monitoring in these cases. Next, please. Decompressive has already been said. I'll just kindly go through them. He has already discussed so nicely. The similar way it has done, but in a decompressive craniotomy for malignant MC, in fact, you need not do a corticostomy, particularly for supratentorial lesion. As he has said, there is doubt that if it's infratentorial or cerebellar, in fact, large, in fact, you can do corticectomy and remove some of the necrotic material, but for supratentorial malignant MC, in fact, the brain should not be touched. Only you do a duroplasty and you keep the bone, as he has said, either bone bank or it can be harvested in the anterior abdominal wall, which can put again after 1.5 months. Again, we had a student who had a project that how quickly can do. Standard recommendation is 3 to 6 months. But we have tried in some cases where the brain is soft, it is lax, and there is no hydrocephalus. As a matter of fact, from 6 weeks onwards, you can put the bone back, otherwise it gives rise to what is known as syndrome of the Triffine. There are a lot of problem of the syndrome of Triffine. If you keep it open and you do not put the bone, there will be a problem, what is known as syndrome of Triffine. For that, we have tried in many cases, almost in 50% cases, we could put the bone flap back after 1.5 months or 6 weeks. Next, please. So this procedure is already discussed. So this is how big you have to make. And as he has very rightly, Dr. Latt has said, you have to do a temporal bone resection. You have to do, otherwise it's incomplete. It has to be a huge one with temporal bone resection. Next, please. Go ahead. Kindly go ahead, because he has already said we need it. Now coming to craniotomy. Craniotomy can be done minimally accessed by rigid endoscopes, by stereotactic guided, or by navigation system, or by ORM. There you need not, because you can directly see how much you have evacuated. You can use this, so minimal craniotomy with hematoma, superficial cortical is there, and there is no massive brain edema, midline shift. This can be done by minimal access technique. Next, please. This is a craniotomy, simple craniotomy. This again, this one is simple craniotomy I have done, and the patient has improved. Next, please. This is what the stereotactical, how you evacuate you put the if a patient he is not having very low score, can be sit up, so you can do stereotactic, but these days navigation system is available. Therefore, minimal access craniotomy, there is no need of putting them on stereotactic frame. You can do the navigation. Next, please. Next. So navigation system is an old system which I am showing, but these days newer navigation system is there. Few cell markers are not required, and you can directly go to the, if you have OAM with you in the operation theater, with that you can put the navigation system, and you can minimal access, you can put the shunt, you can do external drainage, and also you can minimal access and remove the clot. Next, please. Real-time navigation, of course, none of our Apollo hospital is having, but is available outside. I have been working there where it was navigation system was there. So since you are not, what can we use? There are few cases, like in this case, there is a cerebral hematoma which has been operated, and patient has become all right. Next, please. So again, this is a large cerebral hematoma which requires definite decompressive posterior fossa decompression along with evacuation of hematoma. Next, please. This again a large gangliothalamic bleed coming to the surface and has been evacuated. In this case, decompressive craniotomy has been done. Next, please. Again, a large gangliothalamic bleed, decompressive craniotomy has been done. Next, please. Just few examples how it is being done. And this is the same case. Next, please. Here, those is elderly, we have done only a EVD, external ventricular drainage, because there is minimal blood and there is hydrocephalus. Next, please. He has improved. Similarly, this is another case, the elderly man having minimal blood and with ventriculomegaly, therefore, a EVD has been done with IC monitoring. Next, please. Here also, EVD has been done with IC monitoring. Same case. Next, please. This is hydrocephalus. So another case, elderly man, more than 65, but here we have done minimal access evacuation of the hematoma. Next, please. Same. Next, please. Here also, EVD has been put. The hematoma is not very big. It's a gangliothalamic area with intraventricular bleed. So we have done a IC monitoring with EVD placement. Next. In same case, next, please. So when surgery is not helpful, very important to know when surgery will not be helpful. There will be pressure that you do this operation. What has happened, suppose you will find that bilateral pupil dilated and fixed. There is no brain function. There is no brainstem function. Patient on ventilated support and patient on inotropic support. There is no brainstem function. In such case, you operate, I do not think they will benefit. You might pressurize, you may put a EVD, you may do a IC monitoring, but such cases, you will find some of the cases, as soon as they reach the emergency, you will find the brain activity, brainstem activity is not there, pupil is dilated and fixed, spontaneous respiration is poor or is not there, he is already ventilated, and he is on inotropic support. Such cases, if you do any procedure, it is not going to improve. So one has to select which case cannot improve. You may be forced sometime to do this, but one should accept. Next, please. Now coming to the outcome of stroke management, at one end is the death, the other end, as I said, our professor during undergraduate days, he used to be professor of neurology. He says if there is hemorrhagic stroke, 50% die at home, another 25% die en route to hospital, and another 25% those who is all cases of stroke. Another 25% those who reach hospital, they subsequently die of those antibiotics or things are not there. Therefore, they'll die of sepsis, they'll die of pneumonia, they'll have bed sores, all these they used to die. But this is not the situation. These days, we have to tackle case by depending the case. Even if the recommendation up to 65 years to do surgery, even beyond 65 years, one must see the case, and each case must be evaluated separately. And as the facilities are available for minimal access, to see how much one must try all these things. Next, please. But this is not my life. One of the person has said, he is around 50 years. This is not my life enjoyed prior to my stroke, nor it is how I envisage spending my 50s. However, it is still a life worth living. There will some people, family, they'll say, because nowadays 40, 50, 60, you can, any age there is definitely ICS there, though it is 10%. When the ICS patients are, they beg that you do something, he should survive. But you have to explain them where patient cannot be done anything or he will not able to survive, nothing can be done, must be explained. Next, please. This is for postgraduates. This is for prevention of stroke. Professor Kaul always says, so BP, cholesterol, smoking, diabetes, arterial failure, heart conditions, diet, exercise, family, this must be explained to the relations and to the patients that these precautions must be taken to prevent. If there is once hemorrhagic stroke, there is likelihood of developing stroke again, either ischemic or hemorrhagic. Therefore, they must be told that after the incident, how to prevent the stroke, they must be explained and must be spoken properly. Next, please. To conclude, India is witnessing stroke epidemic and urgent action to stroke policy, the need of the country, what Professor Mishra has said in 2010. All ICS patients need supportive treatment. In certain cases where the patient is deteriorating fast with increased ICP, herniation or impending herniation, neurosurgery should be immediately undertaken where life can be saved. Next, please. Neurosurgery plays an important second-tier role in the management of ICS. Neurosurgical consultation make a remarkable difference for the unfortunate victim of ICS. As soon as a patient of ICS comes to the medicine or to the neurology side, the neurosurgeon must be at the same time given a consultation, see whether something can be done, how it can be. Combined decision must be taken in such cases. Therefore, in tertiary centers as well as other hospitals, neurosurgery and neurology should work together. And next. Again, next. Thank you. Next, I welcome. Next slide, please. Next slide, please. I am welcoming all of you, all the neurologists, neuroscience students sitting here. We are having NSI this year on 14th to 7th December at Bhubaneswar. I request all of you to register quickly because end of this month we have kept the early bird registration and you must attend. Bhubaneswar is a beautiful city and you must attend this conference. Thank you very much.
Thank you, Dr. Sahu. Are we going to have any questions? Anyone's got questions?
One comment on ischemic stroke interventions. I would probably go by the flare images rather than the diffusion images because diffusion images will guide you to early interventions like mechanical thrombectomy or not. And we go by diffusion flare mismatch to see what is the actual permanently damaged tissue versus how much can be salvaged. On the other hand, so ultra early surgery, I would probably think twice based on the diffusion images. On the other hand, CT scan is showing a established infarct. Or if the flare changes on MRI, then probably one might consider decompression, and that would be a prophylactic decompression. And prophylactic decompression would probably be recommended either for a stem of IC or the proximal MC occlusion. Whereas if the perforators are spared, then we have to wait if actually to see if the patient deteriorates or not. That's your comments on that.
Diffusion, I think just a large involvement of the diffusion just shows the area of already established infarct, I think. Diffusion shows that. And that your mismatch is used for guiding treatments like thrombolysis and thrombectomy. But for a developing malignant infarct, what is correlated now is the diffusion weighted image.
As a matter of fact, there is a criteria for malignant MC infarct. Once the individual developed malignant MC infarct, of course the medical therapy has to continue, but doing thrombectomy in MCA territory, I don't think they are going to. Already infarct has happened. So you might do a certain procedure once he survives. he may do anastomosis, he may do other procedures, but it is recommended that the patient will survive and can have a useful life, provided a malignant MC in fact has been detected clinically as well as. Suppose it's going down, the score is initially it was 13, 14, coming down to 8, 10, and malignant MC has developed, it has to be operated. And all the trials have said, they have, as a matter of fact, abandoned, they found all the patients who was operated plus those who are medically managed or intervention. Intervention will not help when already a malignant MC in fact has developed already. It is to save life only, you have to do, this is not that function, but some of the patients, they do recover for their functions, so it has to be done, that's the recommendation.
Yeah, Dr. Sahu, one question for you. Do you use any hemostatic agents after evacuation of hematoma in the hematoma cavity?
So at the background, as you said, suppose somebody having some cardiac problem 1 month before, as a matter of fact, that stenting or angioplasty which has done, that may be the cause of the bleed. That may be because they start anticoagulants, and in that they are to bleed. What you do, suppose you evacuate and 48 hours you repeat a scan, there is no bleeding, you can start heparin, which can be reversed. Normally we start heparin, other things we have not tried. Our cardiologists take into confidence, they come and they start heparin, we start. In such cases only. Otherwise, for ischemia to prevent, I do not think it is required that after 48 hours you start. It's to prevent complications if somebody has operated for cardiac surgery or some stenting angioplasty had done. Normally, after 48 hours, heparin is started and it is monitored.
Comment has been made, sir.
Master, so whatever
You have already made the comment. Thank you.
Yeah, I think, thank you. We had a good session. So now I invite Professor Call to give momentum to our speakers. Please, sir. So first speaker, Dr. Rahul Lath, please. Professor Sahu, please. Thank you. Thank you, sir. Thank you. I think now we have one very important thing. Today is Dr. Pratap Reddy, our chairman's 90th birthday, and it coincides with our stroke conclave also, neuro conclave. And Pratap Reddy, sir, he doesn't need introduction, but of course he is the pioneer in modern healthcare, private healthcare. And the first Apollo Hospital, Chennai was started in 1983, 40 years back. And then from there it has grown to the biggest healthcare provider in the country. So may I invite Professor UK Mishra, sir, please. Just like one token, the main birthday is happening in Apollo Hospital, Chennai. And so we thought we'll just Sir, Sahu sir, please come. Dr. Rajesh, Ratnam, Rahul, please come. Call, sir.
Yes.
Yes, to do it. Rajesh, Ratnam.
Thank you, sir. Thank you.
Thank you very much.
Thank you. So I think with this we come to the end of our Neuro Conclave, and I thank, many people are still in the hall even after 1.5 days. First of all, I thank all the speakers and also Apollo management and INTAS group, Celestia. They have supported fully this conference, and I think that's all from my side. I would like somebody from the sponsor group to please come and say a few words.
Thank you, sir. Thank you. And now we are at the end of this beautiful Neuro Conclave, Apollo Neuro Conclave. And I, Arun Chadha, on behalf of INTAS Pharmaceutical, would like to say thanks to all of you that this conference really it's a memorable conference for us also. And I would like to thank Dr. Sudhir Kumar sir for designing such a beautiful conference. And he has invited all the faculties, not only from Apollo, from outside Apollo also. So that gives really a good experience. So on behalf of INTAS Pharmaceutical, we will definitely convey that we will continue with such type of educational programs for all the faculties. Thank you. Thank you very much, sir. Thank you. Yeah, lunch is there. My request to each one of you, please take your lunch outside. Thank you.